Happy New Year to you all. This morning we're going to have a very full and interesting meeting, and we're going to hear about the way the county is responding to COVID-19. We've got teams of wonderful workers striving to beat this pandemic, and it looks as if we have turned the tide. The numbers are going down, so that's really good. So thanks to all the people in adult social care, in the NHS, the fire services, and anybody I've failed to mention. Thank you for your sterling efforts in beating COVID-19. We will get there in the end. It all depends how many holes you have in your arm, I guess. So can I introduce you to Brian Robinson, who is the chair of Health Scrutiny. Brian, do you want to say a few words?
Yes, thank you, Stephen. Yes, good to welcome the Health Scrutiny committee members to this meeting. It's an opportunity to ask questions directly to public health, and I think it's going to be a very large meeting. So I think we'll leave Stephen in the chair position so we don't get any muddled position. But it's an opportunity for all of us to get a full update on the way the COVID-19 pandemic is changing in Gloucestershire, and let's hope that everybody gets a chance to ask the questions that they've got. So over to you, Stephen.
Thank you, Brian. Thank you. Apologies for absence. Joe, do we have any apologies?
The only formal apologies that we've received, Chairman, are from Councillor Phil Alford, and we welcome Councillor Brian Tipper to the meeting, who is going to substitute for Councillor Alford. Thank you.
Yes, welcome, Brian. We hope you'll have an interesting, well, we know you'll have an interesting morning. Next item number 2 is declarations of interest. Do we have any declarations of interest? No. Okay, thank you.
Chairman, could we just remind members that if they wish to speak at the meeting, if they could use the raised hand device on their laptops. If they have problems attracting your attention via the raised hand on the laptop, if you just put your hand in front of your camera on the screen, and either Councillor Hurst or myself will try to make sure that we've added you to the list of speakers. And if you could just also lower your hand when you've actually finished speaking. Thank you.
And one top tip, if things go wrong on the system, it's recommended that you turn your picture off and rely on the audio, which seems to get a better service than both together. Okay, thank you. Right, can we now go to number 3 and confirm the minutes of the meeting held on the 10th of November, and that's for members of adult social care and communities scrutiny only. Has anyone got any matters they wish to raise about those minutes? Otherwise, does anyone wish to propose that they are a true and accurate record? Okay. This is when you have a problem and you can only see a small number of people.
I'll propose they're a good record.
Thank you, Brian. Would anyone wish to second that?
Yeah, happy to second that, Stephen.
Okay, Steve, thank you very much. Those in favour, please. How do we do this, Joe?
Stephen?
How do we catch a vote that we're all in favour of adopting the minute?
I think if we take it that if there'd been any objections, that somebody would have spoken. So we're going to confirm the minutes, yes, taking that there've been no comments or observations. So the minutes are approved. Thank you
very much. Are we all happy with that? Thank you. Now we come on to item number 4, and Sarah, our new Executive Director of Adult Social Care and Public Health, is going to give us a report on the department's response to COVID-19. Sarah.
Thank you, Chair. Can you all hear me? Yeah, great. So good morning, everyone. It's lovely to see you. So we've sent 2 reports today. So there's the report in your pack, which is the combined adult social care and public health response to COVID. And first thing this morning, we sent out an intelligence report. I'm sorry this was so last minute, but we wanted to make sure we were giving you the most up-to-date information. So having had a discussion with both chairs, what I propose to do is talk you through the intelligence report. I'm assuming you've read the report in your packs, and then we'll leave plenty of time for questions on the information that I've presented to you. So if that's okay. Thanks, Joe. Joe shared her screen. If we skip through to slide number 4, please, Joe. And this slide gives us an overall indication of where we're going with our numbers. And what you'll see on slide number 4, when we get to it, is that thankfully our numbers are decreasing, which is really good news. This is almost certainly the impact of lockdown. Our numbers in the community are decreasing. I think we have to be really aware that there's a pattern that we see whereby where numbers, what we see in the community is reflected in our hospitals a week to 2 weeks later. So on slide 4, you can see at the top the number of cases that have decreased. I'm going to talk to my side. There we go. So we've still got an instance of it's quite high. It's 216 cases per 100,000, but it's definitely coming down. And you can see there in the last 14 days, over a 17% decrease, which is clearly very much welcomed. In the table below, you can see that the 6 district councils there. Gloucester City has consistently been our district with the highest number of cases, but that again has decreased slightly, although not particularly quickly. What has decreased quickly is the Forest of Dean. That has had particularly high numbers of cases recently, but as you can see there's nearly a 40% decrease in the last couple of weeks, which is really good news. The Cotswolds has also decreased, but recently we've seen a slight uptick there, and we've looked at the data. There's nothing that's necessarily explaining that other than community transmission, so we'll keep a close eye on it. Other things to point out on this slide are on the right-hand side, in terms of the total number of tests, the percentage of positive tests has decreased. That went up to around 12% just after Christmas. So of all the tests we've carried out in the county, 4.5% were positive. And then the bottom right-hand corner, we can see the number of deaths. And there, the number of deaths registered 28 days after a COVID positive test. And we've now reached 910, which clearly is really, really sad. We are seeing a slight decrease on the previous 7 days, but that's still 910 members of our community that we've lost. So if we then go on to slide number 5, this is one of our early warning slides. We know we've seen huge pressure on our NHS across the country, and we've got colleagues here to talk about that today. But on slide 5, we talk about how COVID symptoms are reported, particularly through 111, whether that be on the phone or via online. And we have seen a fairly steady number of people on our online systems, but a decrease in people ringing the 111 system. We're still seeing, again, adults of working age are the ones that are coming through to that part of the health system. So, and we are seeing a slight increase in the number of people. So, something to be mindful of. If we move on to slide number 6. This looks at who is testing positive in our county. We're still seeing, as I said before, high numbers of cases in Gloucester City. In the bottom right-hand corner, you can see the district rate per 100,000 there. And in the middle, we can also see the age groups. Now, for quite some time, we've seen by far our highest number of cases in the young adult population, those aged 20 to 30, and that's played out in that graph there where you can see the highest peak in those aged 20 to 39. But generally speaking, we are seeing high numbers of cases in adults of working age. Okay, so slide number 7 talks about data at a slightly more granular level, and members might remember that on the national COVID public-facing dashboard, then we share data at what we call a medium super output area level, which is smaller than a district but bigger than a ward. And some of these don't necessarily resonate with divisions as we might know them or communities. They are quite bigger geographies, but they tend to have around 75,000 people in them. And you can see that the darker the orange, the higher the number. What I would say is that these smaller geographies, the numbers fluctuate quite a lot. So we've seen generally high numbers of cases in Gloucester City, but the medium super output areas that are affected has changed a lot. So on the next slide, on slide 8, we can see a list there. So Treadworth and Quedgeley South have been consistently in the top 10 for quite some time now, but we've seen Central Gloucester and Hempstead and Barton there. But more recently, Hynham, Longford and Norton have been added. And we've also seen there in the top 3, Cirencester South. But the number of cases can actually be relatively small. So you can have a couple of household clusters and that can really bump up a medium super output area to near the top of the list. So we are quite mindful of that when we are planning our interventions. So slide 9 talks about deaths by hospital trust there, and you can see there's been a slight decrease over the week of the data we're presenting, whereas slide 10 talks about death registrations as a whole. Certainly in wave 1, we saw a high number of deaths in the community, and that category also included care homes. And we're still seeing that, which is played out in that orange part of either the pie chart or the bar graph. But we are still seeing, obviously, deaths in our hospitals. Slide 11 are the recovery indicators. So we, in our governance structure that is leading the response to COVID, obviously it's really important that we do keep some of our resource dedicated to how we recover from COVID. And there are some indicators there that talk about some of the things that we're monitoring. These have not changed from the previous week. We update these every 2 weeks. Slide 12 talks about the R rate. And the R rate in the southwest is still predicted to be between 0.9 and 1.2. Clearly, we want the R rate below 1. And certainly some of the briefings that I've had suggest that to move out of some lockdown restrictions with a degree of confidence, we need R to be around 0.7 to 0.8. So we've got some way to go yet. Slide 13 compares us to our geographical neighbours. So you can see in the table there, we've got Bristol, Warwickshire, Oxfordshire, Gloucestershire at the bottom. We are quite a lot lower than most of our neighbours, certainly in the southwest. Other places have had much higher incidence. I can't explain that. It's really difficult to try and understand the pattern of this disease. I think we're just grateful for it that our county hasn't borne the brunt that perhaps other neighbouring local authorities have. And the last slide is on excess deaths. So what you'll see on this graph, so the weeks along the bottom, number of deaths per 100,000, the rate of deaths per 100,000 up the side, and the blue line is our rate of deaths in 2020 going into 2021. And you can see that big peak there during the middle of April going into May. And the red line is our 5-year average. And we find that's the most reliable thing to compare our death rate against, because you'll see it's a fairly steady line and it allows for bank holidays and holidays and flu seasons. And it flattens out the line to give us a realistic 5-year average of our deaths. And you can see towards the right-hand side of that graph, the blue line's moving around a little bit, but it does seem to be coming down now, which is really positive, and currently is below the 5-year average for deaths in our population. So I'll pause there. I'm happy to take any questions on the intelligence report, or happy if we move on to the written report in your packs.
Should I take the slideshow down now, Sarah?
Yes, please.
Can those people who wish to ask a question put their electronic hand up, please? And Joe, if you can spy out and see if anyone wishes to ask a question.
I can see Councillor Hodgkins, Councillor Hilton at the moment.
Okay, let's go with Paul. Paul.
Thank you. Good morning. Thanks very much, Sarah, for taking us through. Obviously, a lot of the figures are much better than they were a few weeks ago. The question I've really got is about transmission, because there's so much going on social media, certainly in my area, people getting concerned about visitors descending on parts of the Cotswolds, but they're outside, they're walking around outside, they're doing stuff outside, which everything I've heard, and I'm obviously not the expert, you are, but everything I've heard says that outdoor transmission is very low or, really low risk. Is there any evidence about outdoor transmission? And also, do you have any evidence or facts around where the transmission at the moment is coming from, where the bulk of it is coming from? Is it supermarkets? Is it in the home, family members? Be really helpful to sort of understand those things, please.
Okay, thank you. There are a few questions in there. So the first question, I suppose, about outdoor transmission. We know that ventilation helps. We know that that the 2 metre distancing helps with transmission. We know that hand washing helps with transmission, as does wearing a face mask. So I think doing those things can help to keep us safe. It's the same message. It's probably not going to change. I think I understand we've emailed, haven't we, around some concerns about particular parts of the Cotswolds and tourists descending. And I think there is something we need to think about that in terms of the appropriate message for Gloucestershire tourism hotspots in terms of how do we keep the population safe versus the longer term impact on the economy. And that's a very tricky discussion, but we're very happy to help with that. And I understand the public anxiety about it. There isn't an easy option there. Fundamentally, if you're outside and you're 2 meters away from people, that should really reduce your risk to a very, very low level. But obviously, if you've got, for example, 20,000 visitors descending on Bourton on the water, that you can't maintain a 2 meter distance. And that's one of the things I think we have to contend with as we move into the spring, and the tourist season may potentially start up again when lockdown is lifted. So technically, yes, it is less risk, but we need to make sure we've got some really clear messages for visitors to our county, I think. The other bit there, I think, of your question was around who's getting it, where they're getting it. I'd love to be able to give you some really concrete information about this. It's really difficult to try and pinpoint. Some people know. We see lots of household clusters. I think I would say we're testing a lot more than we've ever tested before. So you would have heard of lateral flow devices, these new rapid testing kits that are available to certain population groups. There's lots of them out there at the moment. And so we know that particularly in care homes, for example, we've had a testing regime in there since July, and that has actually continued to evolve throughout the winter. So we're finding quite a lot of the time in our cases in care homes that quite a lot of people are asymptomatic, and we know 1 in 3 people are asymptomatic. So we're testing more, we're finding more. We know when we go through the contact tracing data that the most commonly identified group are health and social care workers, which might explain the fact that we're testing more of our health and social care workers, we're finding it. Some people think they know where they got it from. Some people, they can pinpoint a household contact. It's not always that easy. I think the point is you can get it from anywhere. And clearly the places you can actually catch it now in lockdown are severely limited, but it's quite often it's very difficult to pinpoint.
Do you have anything else to ask, Paul?
No, that's fine overall. I suppose, just a final point on that final thing you said, Sarah. Do you get any information from Test and Trace about where the transmission is coming from? Does that help at all?
So we get a line list every day, 7 days a week, of everyone that's got a positive test result. We also get feedback from the Test and Trace national system, and you'll see in the report we talk about our own contact tracing service. So PHE were quite keen that local authorities help to support the national Test and Trace effort. So my team now make contact. So if you've got a positive test result yesterday and you'd be contacted by the Test and Trace service, if they fail to contact you within 24 hours, you then get passed to the team in the county council who would try and contact you. And they want to understand where you've been for the last 48 hours and to make sure that you have understood the self-isolation rules and do you need any help to self-isolate, that sort of thing. So we are available. We have access to that national Test and Trace database, but sometimes it's dependent on the quality of the information that people put in themselves. Quite a lot of people choose to use the online form, and it's about making sure, certainly through the local contact tracing service, that we're asking as many questions as possible and using our local knowledge to try and elicit that information, because it is helpful. If we find that there are, for example, before lockdown, there might have been certain venues that were in common, or people were reporting some concerns about social distancing in a restaurant, for example, then we pass that to our EHO colleagues in the districts and all the COVID protection officers, the name for COVID marshals, and they've visited. So we're constantly looking for patterns, but it's not always that easy, I would say.
Okay, thank you. Now we've got Jeremy Hilton followed by Brian Osterhausen. So Jeremy?
Thank you. My question is very similar to what Paul was asking. Looking at the stats that you gave on one of your slides, which shows a considerable number of infections that are happening in the 20 to 60 year age group, working age group. So it really would be, in public health terms, useful to gauge what the lockdown is having an effect on. And it seems to me that the infection rates were probably caused by people socially mixing in those age groups, probably shopping for Christmas during Christmas time, and maybe at work as well, where they have to go to work. So I'm surprised that we don't have better data on where we think those infections are coming from. It's interesting that there's been a big drop in the number of plus 60 age group getting infected, and I imagine that's because they are socially isolating themselves from everybody else and making sure they keep their 2 meter distance if they go out for a walk, and making sure they don't invite people to their homes. And it's the younger people that maybe have been taking a risk, believing that they wouldn't pick up the virus. So it's interesting. It would be really helpful, I think, in public health terms, to actually understand what caused this spike and where it came from. But I think it was a releasing of I went into the shops once before Christmas, and they were packed, and it was quite clear that people must have been passing the bug there. There was people shopping and people mixing before Christmas. So why don't we really have any clear view on that?
I think what you've proposed is a hypothesis, Jeremy, and I don't know that I've got any evidence to back that up. I think we need to be careful not to vilify certain groups in the population, because obviously the working age population are going out to work. We're dependent on our healthcare workers to go into our hospitals, into our GP practices, our care homes. They haven't got the luxury of sitting at home and into a laptop every day. So there's quite a large proportion of that population that have to go out to work every day. They drive our buses, they're security guards, they're porters, and we need them to do that. And so we've done a lot of work with our environmental health colleagues, working with HSE and through the public health team to try and ensure that employers have all the information they need. So where adults of working age are in the workplace, we've done all we can to try and ensure they're COVID safe. And I think when talking to my environmental health colleagues, they've all said consistently that the standard of compliance in workplaces has been really, really high. What I think we see is that, and I'm talking in general terms now, that we see a lot of employers have worked really, really hard to make their workplaces COVID-free. We've also done a lot of work with the local enterprise partnership. I've done so many presentations and tried to raise awareness with different of the different employer sector groups that the LEP have. What we see, I think, is that, and we've seen this in large outbreaks in the parts of the country, that people go to work, they abide by the social distancing, COVID-safe measures whilst they're at work, but perhaps when they go on their lunch break, cigarette break, or they're getting to and from work, they're perhaps not paying as much attention. Now, that is a generalisation, but there's been quite a lot of evidence in the look-backs, in the lessons learned from larger outbreaks that is the case. So we tend to focus at the moment on car sharing. We know car sharing is a particular risk. We know break time, quite often you can be in a very COVID secure workplace, but you go to have your cup of tea and you take off your PPE, and people are sat next to each other, looking at a magazine or looking at each other's phones and things. It happens a lot. I think we're all working in extremely difficult circumstances, and I'm not blaming these people at all, but I think it's about making sure they have that information and constant reminders that they need to adhere to the guidance. In terms of whether we actually know, it's really difficult, because I can't say for certain how or where someone caught it. We know if people have it or not. We can test for that, and we can understand, well, there's a certain incubation period. Where have you been? But whether we could be absolutely sure you've caught it from a supermarket, or from being on the bus, or for going, when you could go to the pub or whatever, it's virtually impossible. So I recognise your frustration. I am frustrated too. I think what I would say is I've got teams looking at the data every single day, where we are seeing places where people might know they've been to certain places, or they're concerned about COVID safe practices. We do visit and use, I think in the report I referenced some of the additional COVID monies we've got. So we have invested in additional environmental health officers, and then we've had some national money, and the districts have had national money for COVID marshals. So there's a whole team out there trying to enforce this, but we're never going to know categorically where everyone caught it.
I wasn't expecting us to know it, 100% where people caught the virus, but it's useful to understand trends and trends compared to the previous first lockdown, when we know that 50% of those who were infected with COVID-19, and the deaths came in the care homes. So we know that it was in a closed environment where people were working in and living together is where the infection rate rose dramatically. On this occasion, we can see the big increases with
thank you.
with the working age population. Therefore, therefore we should see what is helping to reduce the infection rate now and to carry it on that way, and to what.
Can I just confirm that we do have we have listed to ask questions. You don't need to wave hands. We've got Councillor Lydon, Councillor Dobie, Councillor Gravels. We can see that you've raised your hands, and I think the chairman will be coming to you.
Sorry, can I just respond to Jeremy? Sorry, because I think the other thing to remember is that we can't compare wave 1 and wave 2 directly, because we've got much greater testing capacity now than we ever had in wave 1. In wave 1, quite a lot of people couldn't even get a test. So we're testing routinely high-risk groups. Lots of groups of staff now are being tested twice a week through lateral flow tests. So we're looking for it and we're finding it. So I'm not sure that if we had this testing capacity in April, May, whether we would have seen a different pattern. And certainly consistently since we've had increased testing, we've seen adults of working age have a higher prevalence of the disease. But the outcomes generally are worse for people who are older and over 65. So I think I take your point, Jeremy, but I don't think we can directly compare wave 1 and wave 2 because of the testing capacity issue.
Okay, thank you, Sarah. We just got a little difficulty with people who wish to indicate they want to speak. Because we can't see everybody on one screen, we're seeing hands wave left, right and centre. Can we try and use electronic hands, please, for people who want to ask a question?
Hands raised at the moment are Councillor Lydon, Councillor Dobie, Councillor Gravels. So we have got people raising hands electronically.
Brian, you're next. But you're on mute. Brian, you are on mute. Who have we got after Councillor Hauser? We've got here comes the lady on a white horse. Now this is what you do, Brian.
There. Can we come back to Brian? We're there. Okay.
Thank you, Carol. Sorry, Sarah. It just didn't want to open up. Over the last couple of weeks, there's been arguments in the news, I've noticed, about the second vaccination, particularly for old people. Some have claimed that they're going to have to wait for 12 weeks, having been told that there was a 3-week wait before they go to get their second. Can you tell me what the situation is now? Sarah.
I think so. Partly this might be a question for Andy and Mary, but I think there's been a national policy decision, hasn't there, to delay the second dose because there was a good enough immune response from the first vaccination to allow a greater proportion of everyone in those at-risk groups to have their first dose. So my understanding was that we were following the national policy direction, but Andy or Mary might want to add to that.
There has been discussion over the last 2 weeks about it, and the feeling is that they should not be 12 weeks but 3 weeks.
Can we cover vaccination on the next item, please?
I think that this will be covered in item 5, Brian. I think vaccination programme will be coming in the later agenda items.
Brian, please.
Thank you very much.
Thank you. And the next person is it Councillor Dobie?
Councillor Lydon, Councillor Dobie, Councillor Gravels.
Yes.
So is it me next?
Yes, Steve.
Thank you, Chair. First of all, lovely to see you all here. Good to see you health and well. And best of luck to Sarah for, well, I think a huge job. So you deserve all our credit and blessings and bottles of champagne for doing this. I wish you well. My question is about and I may have asked it in the wrong place, but forgive me, was about the amount of people that are still in hospital that I understand are fit and able to come out, and which is why it's important, I think, to have meetings like this where adult social care and NHS colleagues are in the same meeting. How are we actually doing in terms of getting those people out and getting them back into the community or into the community homes or getting them back home? Some of you might remember 4 years ago, we were calling it bed blocking, which I'm told is now not allowed to be used. But for simple people like me, it's the term. And it's a critical issue, I think, for many of us, that those are expensive resources in hospital. But we know some care homes, of course, are nervous because of what they perceive to have happened at the start of the crisis, i.e. taking back people that might be infected. So,
do we want to, sorry, Steve.
I finished.
Do we want to ask Deborah or Mary to answer this question?
I'm happy to start, Chair, and thank you for the question. A few opening comments. Firstly, I can't recollect a time when colleagues in health and social care were working as closely and effectively as I feel that we are now. We do still have challenges, so we've got more than 100 patients in our hospital beds who are ready to leave hospital and go on into the next step in their pathway. But again, positively, that's far fewer than we had just 2 or 3 weeks ago. I think the other really important thing to note in this is that demand has gone up considerably. So colleagues in adult social care are not placing fewer people into care homes or giving them domiciliary care at home. The demand on services has gone up considerably, largely as a result of COVID. When people leave our hospital, they can still be, relatively unwell and dependent and need that additional care. So demand is outstripping what we're used to providing. There's been some great innovation, both with colleagues in social care, but also my colleagues working in community services. You may have heard of something, Stephen, it's called Home First, which is a way in which we can get people into their own homes rather than a care home to continue with that period of assessment before we make a decision about their long-term future. And what we can see is that if we do that assessment in their own home setting where they're familiar, they're more likely to end up being cared for at home as opposed to going into more institutional-based care. So it is a challenging picture. I don't want to belie that. The hospital would feel very different this morning if those 100 patients weren't in our beds. But I don't think there's much more that we can do. My final comment is just in relation to the comments about COVID and patients leaving our hospitals who are COVID positive still. And that is the minority of the 100 plus that I've talked about. And again, very positively, we're probably about a week away from having a care home in Gloucestershire that's accredited and registered by the Care Quality Commission to take in patients who are still COVID positive. So again, a really positive step. We think it's the right model to just have one care home where we can be confident that the standards around infection prevention and control are as stringent as they need to be. They'll have special laundry provision, etc., etc. So I think it's a positive picture in Gloucestershire and how we're working together, and great that we've come together this morning as health and adult social care to kind of demonstrate that, I hope.
Do you want to add to that, Sarah?
Thanks, Chair. I mean, I would echo everything that that Deb said. I think we have worked really closely together. I think we have really focused on how best to support individuals. I know that in the past, committee members have voiced concern about the level of COVID in care homes, and I think we've been very, very clear on our position on that, and that we've always followed the guidance. We have never knowingly discharged someone with an unknown COVID status. We have worked very, very hard to do that. And the provision that Deb is talking about is something called a designated setting. So this was created, I think the first letter came in early November from Department of Health and Social Care asking us to consider creating these settings. And at the time we were using community hospitals to move these patients who were within 14 days of their positive COVID test. But we have just simply become much more busy as a system. We've seen that increase in patients over the autumn up to Christmas, and then another sort of surge after Christmas. So we are going through all the checks and balances. This was not a decision we took lightly as a system, and it was a decision taken as a system. And we will have 14 beds in this particular facility, hopefully up and running within, as Deb said, within the next week.
Thank you. Is Councillor Dobie next?
Yes, please.
Yes,
Yeah, it's great to see how the debate has now sort of opened up a bit and how we're covering the artificial divide easily between health and social care. But I wanted to ask a question on behalf of one of my vulnerable residents who's come to me about the vaccination programme, and I know it might be later on the agenda, but we're already getting there. A vaccination programme with regard to people who need to be vaccinated at home. And he's concerned because he's not been contacted about it, while his contemporaries, he's in his 80s, he's elderly, have been contacted about being invited down to the local fire station to be inoculated. And I know that's going very well. Now, I've heard that the inoculations that are necessary for people who require the jab at home are perhaps of a different type than the ones that they're being given in these larger settings, such as the fire station. And I was just wondering, in light of also comments that the situation with regard to vaccine is, quote, tight, and there's a problem with that, what's happening about people who need to be vaccinated at home? Because he's not being contacted by his GP practice. Is it up to individual GP practices how they handle this, or is there some kind of county-wide coordination for vulnerable people who are living at home, they're housebound, and they need to be vaccinated at home? I just wondered whether anyone could say something on that subject, because it's of great concern to my resident. Thank you.
I think our enthusiasm is running away with us. There is a specific spot on the agenda for that, but seeing as you wasted your breath asking the question, we'll ask someone to answer it for you.
Thank you.
Well, I'm happy to pick this up, but it does tie in with all the other points we're going to cover over vaccination issues.
I'm happy to have it covered later on if that's the appropriate time. So please move on.
Thanks for that, Ian. Thank you. Who's next, Joe?
I believe Councillor Gravels.
Yes, Andrew.
And Councillor Robinson.
Yeah, hello, good morning. So it's Andrew Gravels. Good morning. I'm keeping my camera off because the connection doesn't seem too good this morning. So I'm going to have this opportunity to thank Sarah Scott and her team for all of the work.
Just lost you, Andrew. Could you just repeat your question?
I'd like to pay tribute. Sorry, I'm just thanking Sarah and all the other NHS colleagues on the call on this Teams meeting for the work that they're doing right across Gloucestershire. I hope you can still hear me okay. Can you still hear me okay?
Carry on, Andrew, yeah. If you could ask your question, that'd be lovely.
So, having thanked them, my question to Sarah is, I represent one of the, and it's concerning rates in Gloucestershire, Sarah, still remain with their outliers. And I just wonder tools there are, toolbox, if I can put it that way, that we have to tackle the high rates that we're seeing in Gloucester. I hope you got that. Thank you.
So I just checked to see if I've understood that. So in bits, I think you were asking, there are still high rates in Gloucester. You're absolutely correct. And what are we doing to tackle those high rates in Gloucester City?
I think that's correct, Sarah. Yes. Yeah.
Okay, so you're absolutely correct. Gloucester City has been the place where we've seen the highest number of cases by far throughout.
The new areas left that we can do in Gloucester.
I think if you carry on, Sarah, and try and answer the questions best you can.
So we really recognise that we've had high rates in Gloucester City, and particularly for some time it was Barton and Tredworth, and we've worked really hard with the community, because I think there's something about we can read all the evidence we like, but we need to try and influence people's behaviour. And to try and influence people's behaviour, we have to get to know the communities and understand what's driving their behaviour. So we've had a team that have been working in Barton and Tredworth with colleagues from the City Council and across the system, with community leaders, whether it be religious leaders or community leaders, to try and understand what was driving the behaviour and therefore the rates in Barton Treadwell. This is not about blaming people at all. It's about understanding how can we help them adhere to the rules and make sense of the rules. Because if you can't sit at home all day and do your work through a laptop and you have to go out, how can we help you do that in the safest way? So it has primarily focused on Barton Treadwell because we also know that the higher proportion of our Black and Asian minority ethnic population live in those two wards. And we know that from the DPH annual report, for example, and the evidence base that there was an increased risk of complications and death in that age group. So we've done some work around understanding that. We've done a lot of work around putting the guidance in different languages. We've done webinars, we've had interviews with GPs translated and put out in different WhatsApp groups. We've written to people, we've sent the guidance in different languages. We've worked with, for example, the chairman of the mosque committees. We've given specific advice to religious leaders. So that's very much focused on Barton and Treadworth. What we have seen across Gloucester City in its entirety is that those medium super output areas with high numbers has really changed across the last few months. Sometimes, for example, at one point Matson was quite high, next time it's Quedgeley South. So we've had a bit of a Gloucester-wide approach with with some of our communications, and there's some detail of that in the report. And also, you would see in the report that our lateral flow testing community testing centre has opened up in Chequers Bridge, which I believe is just in Coney Hill, not in Barton and Treadworth, and that is now open to any of the frontline workers in Gloucester City itself. So a whole range of different things, really. There is no magic bullet at all. I think we know that people who cannot work from home are at higher risk of catching COVID just by the very fact that they're out there mixing, and we know that there are a higher proportion of people in those tend to be lower paid but public-facing jobs living in Gloucester. I don't know if that answers your question, Andrew.
We've got two more people asking questions, Councillor Hurst. We've got...
just very quickly, if I could come back on that. Yeah, sure. So, Sarah, just very quickly, that's an excellent answer, and thank you for that. And just reassure us that you're working very closely with all of your colleagues, and including the City Council, which 3 of the Gloucester members who are on this meeting also belong to.
Absolutely, yes. So officers and members. So we've got representation from Gloucester City on the Health Protection Board and on the groups that sit beneath it. They've certainly been a driving force in the community-based work that we've done in Gloucester City, and Gloucester City Council was represented on the engagement board as well, with the overarching board that's chaired by Councillor Mark Hawthorne.
Thank you, Andrew.
We've just got 2 more people wanting to ask questions, Stephen. It's Councillor Steve Robinson and Councillor Brian Robinson, and they're the last 2.
Joe, I would like to ask. I've been waving all day.
Sorry, Pam, we haven't got your raised hand there. We'll add you to the list. Is there anybody else who would like to ask a question? Then we do probably need to move on.
Okay.
Helen Molyneux, is that right?
Got Steve Robinson next, please.
Yeah, and Helen. Thank you.
Thank you, Stephen. And I'd just like to reiterate what Councillor Steve Lydon said about the teams across Gloucestershire and the fantastic work you've been doing. Thank you. What I would like to ask Sarah is, Sarah, you mentioned about the R number in the southwest at 1.2. And I know you said that the first lockdown was very different. Do you have any idea when, bearing in mind the experiences of the first lockdown, when it would likely to get down to 0.7 during this, during the pandemic?
Brian, can you mute yourself, please?
I'd love to say I did, Brian. I really would, but I'm afraid I don't. I think the decrease in the R rate is very much dependent on our behaviour as a county, as a nation. I think we've heard on the news, haven't we, that there's generally less compliance with this lockdown than we saw in lockdown 1. There are probably many reasons for that. I think lockdown in a cold, grey January is much more difficult than it was in a sunny, springtime. So the more we see people not complying with the lockdown, the greater the potential is for people to catch COVID, and the more cases we have, the greater the R number will be. So it's the same message around, please adhere to the guidance, and some of the work that my team are doing are trying to understand, well, if you can't comply with it, why can't you, and what's if you're not going to self-isolate, why you're not self-isolating, and we've commissioned a survey for those that have been positive. It's an anonymous survey just to try and understand why people are not self-isolating, because we know nationally people aren't. And actually, it's quite hard to suddenly, decide you've got COVID symptoms, have a test, and then not leave your house for 10 days. I don't think anyone's fully prepared for that. But we do have, the welfare advice hubs. We've got support for people to enable them to do that. So I think that's that. I would love to be able to give you a more concrete answer, I'm afraid, but I think we just have to wait and see.
Thank you.
Brian Robinson, please.
Yes, thank you, Stephen. My question's around the schools. I mean, the significant difference of this lockdown is that schools have been closed again. And we're seeing, I think, some evidence that that's helping to push the infection levels down. So my question really is around how significant are schools in the transmitting the infection? And because we have a sort of complex system where I think schools are reporting 30 to 50% of pupils are in school, it seems quite a muddled response, because if they are an infection source, really they should all be closed. And if they're not, why aren't we allowing all students to go there, or pupils to go there with better precautions? Because what we have at the moment seems quite unfair in that it's quite a mixed response for young people. So can we have a public health view on that, please?
Well, clearly the decision to close schools was a national one. I think that we have had examples of some of our schools who've got maybe 50% attendance. There's been a change in the guidance around who is a key or critical worker this time. Last time you had to have both parents who were critical workers. This time only one needs to be a critical worker. And the definition is certainly very broad. So some schools have seen quite a lot of children requesting to attend. I think schools have done a fantastic job, in terms of teaching children in school and then trying to deliver the remote learning as well. It is no easy task, but I think I'm not the director of children's services. I've not had a briefing on this in the last week, but my understanding is that generally we were seeing a 10 to 15%, so 15 to 20% attendance across the country, and in general Gloucestershire was not massively out of kilter with that, but we have got some schools with particularly high numbers of children in there. We also know that children, if they do catch COVID, tend to get it fortunately quite mildly. Some of them are asymptomatic, so it could well be that they are experiencing COVID. We're still getting outbreaks in schools because children are still in school. To say schools are closed actually isn't true. They're closed to some children, whereas some children are able to attend. And there's lots in the news today, isn't there, about the impact of missing school on children, and that was well documented last year.
Can I just clarify, whose decision is it that the children go to school or not? Is that the school makes that judgment based on the information they get from parents?
So any vulnerable child that's under the care of social services is able to attend. Any child on an educational health and care plan is eligible to attend, plus any other child that has one parent who is a critical worker. And as I said, the definition is very broad. I think then it's up to the school to decide whether to allow that child to attend or not. And there have been some instances, I think, when schools have declined, and I know that colleagues in children's services have worked really hard with schools to enable them to accept all the eligible children.
Okay, thank you.
Thank you. And now we've got Pam Tracy, now that she's finished her porridge. Pam?
Well, you'll be grateful. One of the questions has already been asked. But going on from the school, where I'm governor, we have about 50 to 60 in that school, and it does work well, touch wood, but I do feel so sorry for the teachers because, not only, like Sarah, I think hit on a little bit, it's when they got their children to go to in C2 as well, but some schools do take, I think, the teachers' children in. But anyway, going back to earlier on about, I know I've got people who's obsessed in not going out through the door, and they're having people to do their shopping for them. And I heard that people who's not been through the door, and somebody only asked me the other day, they said they knew somebody who not left their house, but they caught COVID. Now, and I said, well, the only people who would have come to your house would have been the people with the deliverers. So when these people leave the deliverers, their food shopping, and I expressed that you've got to wipe it well, but that could be a carrier. And so my question is, would that be a carrier also coming into that house? leaving the food on the doorstep, and that person picks it up. There could be germs on any of that, couldn't it?
Technically, yes, Pam. I think we know that the new variant is much more transmissible. And I think that one of the main pieces of advice has been hand washing, hasn't it? And it's really easy to touch your face or your eyes or put your fingers in your mouth or something. So if you're, unpacking a supermarket tray of shopping,
yes,
it is possible that if you've touched that and unpacked your shopping and then not washed your hands. I mean, some people choose to wash their shopping for that extra level of assurance. You could just wash your hands frequently. It is possible that that's how they caught it. I know that certainly when the delivery people deliver the shopping, they tend to put it on the step and they step back. I get my shopping delivered when I can, and they're very respectful of that. I think they're really good at trying to minimise the distance. I think what I would also say is that a definition of a contact is someone that's been within 2 meters for more than 15 minutes. So they must either be, have a very high viral load to drop the shopping off on the doorstep for 30 seconds and step back and then be able to pass that on to someone.
Yeah, and I'm on about the shopping. What is packed by? There's a lot of young people who pack early in the morning. Yeah. Been lying around, and I've noticed a lot of deliveries don't use gloves or anything like that, and they get out their van, they're touching other stuff. It's just a thought, and I just thought that those germs could be on that, like the veg and all that, because I do stress you've got to. I even wipe the bottom of my lettuce before I put it in the fridge, and I put it in a bowl now, in the bag, in there. That keeps fresher that way. But it's just I don't know how else this little bug gets into the house. Like even on flowers, isn't it? People buy you flowers.
I think hand washing is one of the main ways you can keep yourself safe. And I think a lot of the delivery drivers use a lot of hand gel as well. So there's an awful lot of hand sanitizer that's used to try and clean hands when you can't get to soap and water. Yeah, it's very difficult. It is really difficult.
Yeah, I know.
And I recognise it's really worrying for people.
Thank you.
Thank you. I think we've finished the questions on.
Councillor Helen Molyneux, I think, wanted to ask a question.
Sorry, Helen?
Thank you, Chairman. First of all, I want to thank everybody for their hard work with the care homes, and also recognise the hard work that the care homes themselves have done in keeping their residents safe and their carers. It's been very hard work for all of them. Now, the Forest of Dean figures, as you know, have been quite alarming. Mostly due, I think, to our population. We're not young, we're not rich, and we're not very healthy as a bunch. I'm sure some are. But that increases the risk to the population. Now, some of my residents, you've all heard me go on about this before, the special position of the Forest of Dean, the very western edge, in that we are part of the Wales NHS. Now, part of my ward, those are the people who are most anxious about getting vaccinations. I have phone calls from parish councillors about residents in tears because they're over 80 and haven't yet heard. Now, the latest position apparently is that the Aneurin Bevan Health Board are sending to housebound elderly people teams of vaccinators. That was the information I got last week. Whether that still holds or not, of course, who knows. But the position for some elderly people has just been very sad. Lots of them live on their own. They get very depressed and they get very lonely, so they are worried. Anyway, whether that's any good to anybody, I have no idea. But it's taken, I must say, quite a lot of hard work to make sure that all the care homes and facilities have had their vaccines. And there are still 3, as Sarah knows, that I am particularly worried about, with mixed populations. Now, this I don't understand. If we've got elderly residents and working age adults together in a facility, why are they not all vaccinated? Adults, young adults with learning difficulties, do not understand the concept of social distancing. Why would they? I taught these people when they were children. So my plea is, for goodness sake, anybody who's in any form of residential care, if the ages are mixed, please can we vaccinate them all? Thank you very much.
Thank you, and we'll talk about that in the next one of the next items, Helen, if that's okay. Have we finished the questions on number 4? If so, we can proceed to number 5, which is the response to COVID by the clinical commissioning group. So Mary or Andrew, who's drawn the short straw?
Andy's going to start with vaccination, then I'll do another couple of issues, other couple of updates, and other colleagues then can add. And obviously, I'm sure you'll have questions at that point.
Okay, Mary, thank you.
Okay, thanks. Yeah, clearly the vaccination programme is one of the key issues at the moment, so I'm sure there'll be probably more questions, but I'll try and pick up some of the questions as well that have already been answered. So the vaccination programme in Gloucestershire started before Christmas. We mobilised teams very rapidly, huge amount of work from colleagues right across the system. And just as a reminder, this is a system-wide response. So the hospital trusts are have the SRO responsible for the whole programme, and there's delivery of the vaccine programme in the hospital hub. And there's a large programme delivered out in the community with what are called primary care networks. So just to remind the colleagues who may not have heard the term primary care network or PCN before, these are groupings of practices based around geographies, and even more so for the vaccination programme. They set up 10 particular sites around the county, which you have listed, I think, in our report. Or if not, I'm happy to go through where they are. But they're suitably located around the county, so we've got good coverage. Some are out of practice sites, some are out of shared communities. So at the GHC, the community hospital sites, we're also using the fire station in Cheltenham, and we're also using a community centre in Churchtown. So a variety of locations for the PCN sites. And these are essentially run by the practices, groups of practices to deliver vaccination. So that's the kind of setup. And again, more recently, in the last week or two, we've had a couple of community pharmacies getting on board with delivering vaccines. So there's a pharmacy in Gloucester and a pharmacy out in Bishop's Cleeve. And you will know that we don't have a mass vaccination site in this county for a number of reasons, but we think actually that's a bonus, because we think we can deliver it more effectively at the community and PCN level anyway. So providing we get the appropriate amount of vaccine, we think that's not an issue for us not having a mass site. So in terms of the people to be vaccinated, you're again probably familiar with the cohorts, but I'll just run through the 4 cohorts and touch on each of them in turn. And you will recall also that the target is to try and get all these 4 cohorts vaccinated by about mid-February. So cohort 1 is the care home residents and staff, and we have just over 117, 118 older care homes in the county. And I'm pleased to say that all of our care homes, bar 1 or 2, have had all their residents and staff vaccinated. And the only reasons that the 1 or 2 have not had vaccination is because there's been a significant outbreak in the home. So we need to wait for those residents to get over their COVID and then be vaccinated. And you need to leave at least a 4-week window between catching COVID and then having the vaccine. So that's the only reason we haven't got 100% coverage. So again, great credit to all colleagues for getting that far in that vaccination programme. Then the next cohort is two cohorts. There's health and social care staff, and that's a huge number of people across the county, well over 30,000. And that's largely been delivered through the hospital hub, through Deborah's team. And I don't have precise figures, but I know that well over 50% and increasing on a day-by-day basis. And then the other cohort there is in cohort 2 are the over 80s. And you will have seen, because it hit the national press, that Gloucestershire hit the top of the league table for the percentage of over 80-year-olds vaccinated. Last week we were at 85%. I think the latest figure is 87%. So that, again, testament to the hard work by predominantly the primary care networks, because this has been largely delivered out in the community, this particular cohort. And just to answer one of the questions, I think as Councillor Dobie referred to, so 87% coverage will be a spread at particular PCNs where some have achieved over 90%, some are around about 80%. So some PCNs are going at different rates than others because they were able to mobilise quicker than others for various reasons. So there are still some PCNs where there's still 1 in 5 of their over 80-year-old population still to be vaccinated. They will be vaccinated. I have complete confidence that they will be vaccinated in the coming weeks. But some of these will be housebound as well. So that's probably why in some areas of the county, patients will not have been contacted yet because they're in the 20% who haven't been vaccinated. These are all known by the PCNs. And in terms of who contacts them, it is the practice that's related is in the respective PCN. So, for instance, if it's a Cheltenham practice, that practice will contact the individual and arrange for the patient to, if they're mobile, to go to the PCN site, which in Cheltenham is the fire station. But also, if they're housebound, they will be vaccinated. Again, some have already been vaccinated, but they will be vaccinated in due course. And again, that's where there's a partnership working across the system, and our colleagues in GHC are assisting with vaccinating some of the housebound. So they will be vaccinated in due course. Cohorts 3 and 4 are for the over 75-year-olds and the over 70-year-olds. And again, parts of the county, there's been some good progress and going through those cohorts. I said by mid-Feb, I hope that we will have managed to vaccinate virtually all of those. I say I hope because we are dependent on vaccine supply. And again, you will probably have picked up in the news that there are parts of the country who have not reached the rates that we have. And so vaccine supply is being prioritised for those areas. So it's meant for the last week or so, we in Gloucestershire have received proportionately less vaccine. So it's slowed our rate down a little bit, which I can understand the argument about that. In terms of the second dose, it is clearly a national directive, and we are following that national directive precisely. And I have to say the public health argument makes complete sense. There's clear evidence that if you have one vaccination, it reduces your chance of hospitalisation and also reduces the chance of death from COVID. So therefore, if you've got 100 people, it's far better to give 100 people a first dose rather than 50 people 2 doses out of the 100 vaccine, because then you've got another 50 people out of that 100 protected. So I think there is a clear public health utilitarian argument to support that. And that's why we are following the national advice. And the other comment in terms of care homes and the mixture of age profiles, I agree with Councillor Molyneux there. I think there needs to be a degree of pragmatism, and certainly my colleagues, I understand, are doing that, where they've got some leeway and there's got a mixed age profile. They are trying to be pragmatic about how they vaccinate that population, and that message we are certainly putting out as leaders across the system. Sorry, the only other group I didn't mention is the clinically extremely vulnerable, which come in cohort 4. And again, we are starting to vaccinate those as well. I think I've covered all the points or issues that people raised, but happy to take any further questions or comments.
I think Councillor Lydon has really lodged 2 questions. Councillor Lydon, do you wish to say a question?
Yeah, thank you.
Councillor Horwood.
So who's first? Me?
Councillor Lydon.
Okay, thank you. Just didn't want to step on somebody else's toes. Thank you for that, Andy. And I'm pleased we are now starting to get some of the vaccination data. But what would help us all, I think, is to have a breakdown, like a dashboard of how it is progressing, etc. Because I think the data is key to this, because I understand, I don't read the Financial Times regularly, but I understand local authorities are going to be written to ask for support groups who aren't traditionally taking it up, the vaccine. So that data will be critical. Mine is more about, though, that issue you've made about it's being held back and diverted elsewhere. And again, I think that is very critical for us to understand, because to be fair, it seems like we're being penalised for success. And whilst I'm a fan that the hardest to reach, etc., should be targeted, I do find it odd that we're being penalised for that success. So that's a comment, and I'd appreciate your views on it. And the other one is one we've talked about this before, is eligibility. I understand that foreign NHS workers and a number of people aren't registered with GPs or haven't got an NHS number, as yet aren't eligible to have the vaccine. So I wonder if you could share your thoughts on the numbers and how we're going to sort that out. Because I think the last time we were talking about a considerable number of people in Gloucestershire who aren't actually registered. So, and I think we could talk about the district council and the rest of us trying to help target those groups to actually ensure that they do. So sorry, there's a lot there, Andy, but the data I think is key. And if you could help us on that and just unpick some of those, I'd greatly appreciate it.
Thank you, Steve. Thank you. So in terms of vaccine equity, and that's a hot subject for us locally and nationally, we're working closely as a system with Sarah's team, and Paul Roberts, Chief Exec GHC, is leading a vaccine equity group to make sure that we will target and reach those difficult to reach groups. Because certainly nationally we're aware that there are issues in terms of vaccine equity, and we don't want to miss out groups locally. So I know the work is in hand to do that, and again, Sarah's team have been into different communities in the middle of Gloucester, for instance, and started to work with them. So she may want to comment further on that. In terms of the point about being penalised for success, it depends what kind of language we use. We are still vaccinating. We are still continuing to vaccinate our population, but we have to recognise that the supplies centrally need to be managed appropriately. So I think we just have to bear that in mind. And then the last point in terms of the unregistered population, absolutely agree that is a difficult situation, because you need to have an NHS number to get a vaccine at the moment. NHS England are working on this because they recognise this is a problem, and we hope to have a solution in the next week or two. I know, Steve, you asked particularly about health staff who aren't registered. The vast majority of health staff are registered, even though they might be quite itinerant in terms of moving around the country with their roles. They are strongly encouraged to register with a GP. So I don't think that's an issue in terms of the health staff particularly, but certainly the point is well made. Sorry, I don't know if you wanted to comment about the...
Sorry, I did ask quite a bit, but I suppose the main question is about the data around vaccinations, who, what, where and when, so we can support and assist if there are gaps somewhere. I think that would help us all, because a lot of the questions we all get asked are around that. I also ought to thank whoever wrote the paper, because I think it's an excellent... Yeah, the papers are excellent in terms of the background briefing it's giving people, particularly the one on number 4. I've used that to say to a lot of people, read that first before you come back and ask questions. So really it's the data, Andy, I think would help us all to get a better understanding.
Thank you. Yep. Councillor Hallwood.
Thank you, and thank you, Andy. And I would say I think we owe congratulations to all the colleagues in the NHS and primary care for having really topped that national table and delivered such an effective rollout of the vaccination programme. I mean, I think that's cause for celebration. If we're actually running ahead of the capacity of the national system to give us vaccines, that's in a way the right problem to have, I think. I confess to being slightly puzzled by this diversion thing, because I can't see how, if an area is not delivering as fast, giving them more vaccine is going to improve that. But I accept that's a central decision, not a local one. And my question is actually about this 12-week interval. I mean, I was very supportive on the last HOSC of this strategy of leaving this long interval, on the basis that at the time the data seemed to suggest from the trials that in both the main vaccines we're rolling out, there was something like 90% efficacy within a matter of weeks of people having the vaccine. So in that situation, then it makes obviously complete sense to vaccinate as many people as possible first, because you get a very high level of protection and you start to get towards herd immunity as well. But there is now quite a lot of talk about this Israeli data on the actual rollout there, which is suggesting that the Pfizer vaccine may have efficacy as low as 30%, which does rather drastically change the situation and suggests that maybe we should rethink this. I just wondered what information you or Sarah perhaps have on that Israeli data and whether that's reliable or whether that's being urgently reviewed, or because that does seem to undermine the case for the 12-week interval quite significantly if it's right.
Yeah, I would say that's quite a straightforward answer. That this would be considered at highest level nationally. The JCVI will absolutely be looking at this data, analysing the data, and responding appropriately. I don't think it's for us locally as a system to go and interpret the data on our own back and change our policy locally. I think this is clearly a national steer, and we will hear imminently, I'm sure, if there's a change in policy. Can I just go back to your point, Martin, about the diversion, so to speak? I don't think the supposed or the perceived worst performance elsewhere is an indication of poor performance. It's just that Gloucestershire were working incredibly hard to mobilise rapidly and get themselves in a position to work very effectively over Christmas and New Year, that we were in a position to do that. It's just that other sites have caught up and are now capable to give vaccine at very high rates. So I think it's not like there are worse performers systems anywhere else. It's just that the rate of vaccination is now similar.
Yeah, sorry, I wasn't criticising them. But the fact is, if they've got lower performance for whatever reason, I couldn't see why diverting vaccine supplies to them is going to improve that.
Martin, if you see my comment, although they were slow to get off the mark in terms of run rate, i.e. they are now operating at a level commensurate with the supply that they've been given. So there's no concern that vaccine will be wasted or, as the ministers would say, not reach people's arms.
Okay.
I think Sarah wanted to come in, Chairman. Is that right?
Sarah?
Thank you. It was actually in relation to Steve Lydon's point about the inequalities. So Paul Roberts has very kindly agreed to chair the inequalities group supported by my team. I think it's important to note there are different groups of people that we need to think about. There are those that are in fact called vaccine deniers, those that just don't want it, think it's something awful. There are those that are hesitant, and they need a different approach to help them, to give them the right information, to give them enable them to make an informed choice. And there are those groups that we traditionally find it hard to engage with. They're not hard to reach, we find it hard to reach them, and our services don't necessarily reach them that well. So I think there are three groups that we need to think about in terms of inequalities. We are looking at the data. We're looking, for example, when we've targeted care home workers in the very first wave before Christmas, of those who didn't take it up, and if not, why not? Because that's all really useful intelligence to help us target our comms and nuance them between different groups. So we are looking at that, and there's also some national tools that are emerging that will be really useful.
Chairman, I've got Councillor Parsons, Councillor Dennis Neal, who are wanting to ask a question.
Councillor Parsons.
Very much, Sean, by the way. Thank you all very much indeed. Very interesting. I just want to check on something. You obviously have identified as an important group, the clinically extremely vulnerable. Can I just clarify for me? There's no age limit on that, is there? I mean, it could be anybody from the age of 5 upwards, that's so classified. And secondly, if someone is classified, will anybody who is having to look after them or closely involved with them also be included as one of the early people to get vaccination?
Yes, thank you. Good questions. So obviously some of these clinically extremely vulnerable, or CEV for short, some of this group will be over 70 anyway and be picked up as part of the age-related cohort. But yes, anyone under 70 who's classified as CEV will be included in this first 4 cohorts, so they will be vaccinated. I think the issue about the carer is a difficult one. Certainly, if they're a professional carer, they will be absolutely be vaccinated, and I think there's it's still being worked through how precise the kind of carer group is being managed. I know Sarah's closer to that, and perhaps Sarah can answer that in terms of just the ordinary carer.
There's no ordinary.
Non-professional carer. Sorry.
So I think we call them informal carers, don't we? So the informal carers, my understanding, are in group 6. So the current focus is on groups 1 to 4. So on the front page of the report that I sent you, it's got the 9 groups that are in the first phase that we aim to do before March, April. So we're going to do the first 4 by the middle of February. So informal carers, those that provide unpaid care, are in group 6. So should still be in this first phase of vaccination.
Thank you. Where are we now, Joe?
Councillor Dilys-Neal.
Councillor Neal.
Thank you. Can you hear me now?
Yes, we can.
Good. Can I just ask a few, 4 very, very quick questions? First of all, I'm interested in how the vaccination is being recorded on individual people's records. Do each of the, because most people would be getting their vaccine not at their GP surgery. So does everybody who's delivering the vaccine have access to that person's records? And in that case, are there some GDPR issues around that? That was my first question. Shall I wait for you to answer that and then ask the others?
There are 2 IT systems that record the vaccination. One's in the community, something's called Pinnacle, and in the hospital, it's NIMS, I think. And I understand that they do link up to the GP record, and so they will get automatically input, so that there is a record. But I'm not aware of GDPR issues, and that my colleagues are definitely aware of the potential issues.
Okay, so it's a separate system for the records, the GPs. Okay, so then the next question was, is the rate limiting step for delivery in Gloucestershire the supply of vaccine? We've got enough deliverers, and the rate limiting step is the supply of vaccine.
Absolutely.
So we don't need any more either. Okay, then I've asked this question at a previous meeting, but is there anything that can be done for care home workers in particular who decline the vaccine, apart from education? It's difficult, but I know of some care home workers who don't want to have it. So
I think Sarah's responding. She can answer that.
I think we're trying to, as I said, gain some data on who's declining, because this is about choice, and we just need to make sure that people have the right information to make an informed choice. We're trying to encourage people to go to reputable sources for their information about the vaccination. If you don't wish to have it, then you don't wish to have it. But I think it's important to note that we've still got the PPE, we've still got the regular testing in care homes. So that's kept a lot of people safe up until now. And I think we need to also recognise that this is a massive mass vaccination programme on the scale that the world has never seen before. And I think, this is a personal opinion, we're probably still going to be rolling this out towards the latter half of this year. And we know at the moment the vaccine isn't licensed for the under 18s. We know that phase 1 takes us up until those are aged 50. Phase 2 indicates that it'll be at front-facing occupational groups. So there's still quite a large proportion of the 18 to 49s who are not in public facing roles who will need to be vaccinated in a third phase. So we'll still be seeing outbreaks in the adults of working age population and in schools throughout this year. And it remains so vitally important that we recognise that how we must adhere to the guidance and continue to use PPE appropriately, because that's pretty much the only thing we've got to give people if they haven't got a vaccination, particularly those working in high-risk environments like a care home.
Okay, and then just finally, very briefly, would there be any virtue in giving the frontline workers, where we really want them not to be sick, to support each other at work? Would there be any virtue in prioritising them for having their second vaccination slightly earlier?
Well, I think we've already set out the argument, or the background why we're supporting the 10 to 12 week gap for the second dose, and I think that remains the same for any person in the vaccination.
Okay, thank you very much.
Thank you. Do we have the next questioner, please? Who is?
I don't appear to have anybody who is wanting to ask a question. If anybody wants to wave their hand at the camera, but I think that's the end of the questions. I don't know if Mary or Andy want to come back in on anything.
I think Mary, sorry, Martin. Yep.
Well, I was just going to say, if
Martin?
nobody else wants to ask another one, I'll ask one more. And it does slightly come back to the issue about that was asked in the previous session about the incidence of the of COVID infection and where transmission is taking place. Because I can't remember which it is now, but I think one country has started to vaccinate school children on the understanding that schools are one of the places where transmission is taking place. And if some schools, I gather, up to 40% attendance because of this broadening of the definition of key workers, and certainly I've seen outside one local school, frankly, a crowd of parents and children outside the school at pickup time.
Yeah, great.
Is there some logic to vaccinating school kids so that they are not vectors for transmission to the wider community? And is that being looked at?
The key issue, I think, Martin, aside from the public health policy and the evidence base, is it's not licensed for use in that group. So until it's re-licensed and regulated differently, that's not even an option, unfortunately.
Sorry, I don't quite...
Sorry, I didn't quite
Just
catch
explain
your
that.
first few words, Deborah.
Yes, to deliver a medicine of any form, including a vaccination, it has to be licensed and regulated for use in a particular cohort, either determined by age or by other factors. And these vaccines are not currently licensed for use in children of a certain age. I think they vary. I believe it's under 12 for licensing, but under 18 for regulation.
Interesting. Thank you.
And that's obviously, you'll appreciate, Martin, I'm sure that's about who they're able to recruit ethically into trials.
No, thank you for that.
Mary, you've been sat there patiently listening. Do you wish to say something?
Yes, I'll just update the committee on a number of areas, and then maybe there are other areas for questions. If I could just say, first of all, around the vaccination, I put in the chat that we just want to pay tribute to all the volunteers. We've had a number of voluntary organisations who've been running the logistics, which has been tremendous for the PCN sites. And we've also had a lot of volunteers come forward. And of course, our fire service colleagues have been heavily involved. So it's been a true partnership approach in Gloucestershire, which is why we've had confidence that the model we have was able to mobilise quickly and is a sustainable model to deliver the rest of our vaccination. So just a couple of other things to update the committee on. We have discussed many times about personal protective equipment and training, and particularly training in infection prevention and control. And we are continuing with our work on personal protective equipment, and we have deployed a number of staff who actually work with the Gloucestershire Fire and Rescue Service hub to work on storage and delivery, and that continues and it works effectively. And we also, you might remember, in spring delivered infection prevention and control to all our care homes, and now we're providing ongoing support, particularly during outbreaks. And that has really supported care homes to manage people effectively. And we're about to roll out a refresher training program to care homes. So in terms of testing, this has been mentioned quite a number of times already. All our NHS staff now are using lateral flow tests to check their COVID status twice a week. And that's now been rolled out also to dentists, optometrists, community pharmacists, hospices and independent hospitals. And maternity partners can also access a lateral flow test. We continue with the testing for anyone who is booked in for a planned procedure, a diagnostic test or admission to hospital, where that needs to be completed 72 hours prior to their admission. And we have sufficient capacity, and that is also working smoothly and well settled in. You will have heard that we've had very high numbers of COVID admissions over the last month. This has been probably the most pressurised month that any of us can recall in the NHS. And we had around last week, we had around 26% of acute hospital beds occupied, slightly lower now. We're seeing a plateauing of numbers, we hope, and we expect that, of course, ITU, which follows on from admissions, will increase over the next couple of weeks. Gloucestershire Health and Care also have a number of people with COVID in their beds, where we actually discharged some people from the acute hospital to provide flow in advance of that designated care home setting we talked about earlier. We mentioned briefly the work around discharge, and I think we would say that the work across the system on discharge for the last month has been nothing short of phenomenal. And we have been able to see significant numbers of complex discharges. We have, as we said, have the principle around home first, where we move people home if we can with support, and we have new services stepped up working across the Council and Gloucestershire Health and Care to support that that Home First initiative. We've also been using significant numbers of assessment beds across the system. We've released continuing healthcare staff, adult social care staff and rehabilitation staff to work with those assessment beds, because it's very important that we monitor people and support them when they're in an assessment facility, to ensure we plan for their discharge first of all, but also that we actually enable them to get the right support there and not decondition while they're in that assessment facility. We have indeed also stepped up our work on Synapses, which you'll be aware is a tool which allows GPs and indeed SWAST and other parts of our system to contact the acute trust consultants and to get advice on how to manage patients more effectively and not to admit people unless they absolutely need to be admitted. We also have more clinical support in 111, you'll be pleased to hear, and we've stepped up our frailty services also to help and support people in the community. We have an initiative which is called Oximetry at Home, which is our virtual COVID ward. We're using running these jointly. COVID ward tends to be a step down from hospital. Oximetry at Home is where GPs and other colleagues step people up to a service set up to measure their concentration of oxygen with daily calls from clinicians to monitor individuals and then to provide advice and treatment to them and to be clear when that person will be best served by being admitted to hospital. So Gloucestershire is unusual in that we have a very large number of people with over 350 patients being cared for in that arrangement in the community. And clearly that is supporting our overall system. And we wonder how we will develop that thinking as we move through COVID, and we wonder if it will apply to other services as well. So just to say that we know that we had a number of operations and diagnostics tests cancelled, and we are continuing to ensure that those who have a diagnosis of cancer are being treated, and that we've managed to maintain that during this second wave also. But we do know that there will be a lot of people who've had operations cancelled, and there will be a lot of work to catch up on in the coming months. And I think you would recognise yourselves that there's been a significant impact on staff. This has gone on for a long time. People are very, very tired. People have also experienced trauma during this whole experience of the pandemic. And we need now to think about how across the whole system we offer people specific support. And maybe some of my colleagues might like to comment on that further in a moment. So that's my update.
Does anyone have any questions of Mary? Somebody does.
It's Pam. Yeah, thanks, Mary. Well, thank you all. I was just thinking, like on block, I was asked the other week, but I'm going to answer my own question here because I did find out.
Are you going to share that with us?
Well, yeah, I suppose I can mention things, can't I? I was a village, right? Now, there are some people, we got these homes, like city homes, Guinness homes, and they're in blocks of flats, yeah? Now, some people in those flats are being tested, and some had not, but they all use the same front door. Now, going to the village, the retirement homes, which we have around the county, they live independently. And the question was asked by the residents' chair to me. He said, Pam, wouldn't it be a good idea if we all tested on the same time and day? And I said, what a wonderful question. I said, I'll find out. And I said, it would make sense. So I by chance, when I was doing my walk, I happened to see someone who could answer that question. And I said, I've just been talking, blah, blah. And I said, it makes sense, doesn't it? That why don't, like the village and places where they use front doors, like the social housing, retirement homes, little blocks of flats, could not. And they said, no, because what it is, Pam, they said, we got to do it on the age group, which is right, and you go down. So some people in those blocks could be 80, 90, and some in there could be 55. Now, listening to it all, wouldn't it, my question then would be, would it not if we got round the table and said, well, let's do all that block, let's do that block, let's do that village. But I think you're all doing a good job, and perhaps you're the one who could just answer that. It's just a food for thought. Thank you, Mary.
Pam, do you mean vaccinated or tested at this point?
Vaccinating, sorry.
Vaccinated. Yes, the vaccinations are being worked through in order, and people are being pulled through a system. So I guess we'll be through all of the cohorts in the next 3 weeks, those top 4 cohorts. So I don't think they'll be able to change the system at this point.
No, I just thought it would make sense, really. But but there again, where does one stop? Thank you.
Yeah, thank you.
Thank you, Mary. There's one person that we haven't heard from yet. That is Ingrid. I think Ingrid is with us from NHS Foundation Trust, Gloucestershire Health and Care.
Chairman, sorry to interrupt. I think Sarah Scott just wanted to make a quick point before Ingrid is brought in. Is that right, Sarah?
If yes, please, Chair, if you wouldn't mind. I just wanted to respond to the question that Ian asked and Wayne's response in the chat. I think we all appreciate that there's huge demand for the vaccination. We all clearly want it. We want to move back to a degree of normality. And I think it responds also to Martin's point about the Israeli experience as well. The approach that we've taken in the UK is that we're based on the evidence that the main indicator for adverse outcomes for COVID really is age. So the older you are, the more likely you are to have complications or to die from COVID, which is why we're focusing our vaccination programme on the older age groups and those working with the most vulnerable. Comorbidities also comes a close second. I think there's a very, very live debate about those workforces that are exposed to COVID through their public-facing roles, such as teachers, police and fire at the same time. But I think that is a live national debate. And at the moment, the Joint Committee on Vaccinations and Immunisations has produced a list of 9 priority groups you've got on your report from me, and that's the one we're working through at the moment until we get advice of a change of policy. Just wanted to put that into the mix as well.
Okay.
Thank you.
Let's clarify that, Sarah. Thank you. Ingrid, are you with us?
I am indeed, Chair. Thank you for the opportunity to speak. For members who don't know me, I'm the chair of Gloucestershire Health and Care NHS Foundation Trust. So we're the organisation which provides community health, mental health, disability services to the county. I would just like to say that our trust colleagues have been working incredibly hard and with great dedication, as have all of our colleagues across the NHS and social care. But I think what we do is less visible. Most of our services are delivered in people's own homes and in community settings, as well, of course, as in community hospitals and mental health and learning disability inpatient units. So what my colleagues do is not so readily seen, perhaps, that they certainly have been absolutely flat out. And the trust services play a really important role in avoiding hospital admissions through things like rapid response services such as that. It's already been commented that Home First, which is one of our services that we work with social care very closely on, is instrumental in ensuring early home discharge. And of course, we work with our acute colleagues in terms of ensuring good bed flow through from the acute hospitals to our, at the moment, 176 community hospital beds. We also have a really important rehabilitation role in the trust, and at the moment we are taking the lead in developing the COVID rehab service, which is very much needed as we now know more about long COVID. I think it's also worth just flagging that our trust works with some particularly vulnerable groups that you may not think about as readily. So we have services that are specific to the homeless population, for example. Another example will be the Sexual Assault Referral Centre, very much needed during this lockdown period. And of course, mental health and living disability services. And I would just like to highlight the huge challenge that my colleagues in those inpatient services are facing, treating people who are really seriously unwell, whilst wearing PPE. It's really not easy, and they're doing an amazing job. Eddie O'Neill is with me. He's the Deputy Director of Strategy and Partnerships, and I'm sure will be.
Someone's got frozen or.
Oh, hi. Good morning, everyone. It's Eddie O'Neill here.
Good morning, Eddie.
Good morning. I've just switched my video off because I appear to have a weak signal this morning. So hopefully that's okay, and colleagues can hear me.
Hear you.
That's great. Thank you. So just to pick up the thread from Ingrid, from a GHC perspective. I understand that there was a briefing paper submitted to the committee this morning, setting out some of the key issues for GHC in terms of our response to COVID. So I'll just draw out the headline points from that briefing paper. As you will no doubt expect, COVID continues to be a huge area of focus for the Trust from an operational perspective, as it has been indeed throughout this last year. However, unlike the Wave 1 period, we have, through Wave 2, continued to provide all of our essential services. However, there has been a need in recent weeks to introduce a partial suspension to some of those non-urgent services as a result of some of the staffing challenges that we have, and we've had to redeploy some of our staff to support some of the essential services to keep them running at optimum. In terms of testing, I think Sarah mentioned it earlier, the lateral flow testing. We've been carrying that out for some weeks now for all of our staff, twice per week for all of our patient-facing staff, and that's helped somewhat to reduce the transmission. We're also continuing to provide the testing centre at Edward Jenner for all staff and families, and that's supporting GHT and social care staff. We've also very recently, following the allocation from NHS England for some funding to develop a long COVID clinic service. That's a service that will be introduced shortly for any individual that's been suffering symptoms 3 months post-diagnosis. And we're currently testing out the service model for that with our colleagues in GHT and primary care, and that will be a multidisciplinary team approach. In terms of the vaccination programme, we continue to play a key role supporting both GHT in terms of vaccinating all health and social care staff within the county, and that's a rather large number. I think Andrew mentioned 30,000. So that's a considerable part of the population that we're supporting the vaccination of. But we're also working very closely with our primary care networks, as Andrew mentioned earlier, to deliver the 10 sites throughout the county. And in fact, I think 3 of our community hospitals are being used as sites for vaccination in different parts of the county. I think, as has been mentioned by both Debs and Mary this morning, I think that at no time before have we ever worked really closely together as a system, and GHC has placed maximum effort supporting the wider system in terms of ensuring patient flow, supporting discharges into our community hospital, but also to the Home First service model. that probably covers the key points that Angela's covered in her paper. I'll pause now and invite any questions, and I'll do my best to answer.
Thanks,
And
Eddie.
Chairman, I think we've got two people wanting to ask questions who've got their hands up, and that is Councillor Martin Horwood and Councillor Brian Robinson. Before we go any further, would that be possible?
Yep, fine. Martin?
Thanks. I'm sorry, my question was from the previous session with Mary. I did have my little electronic hand up. It's just on the Home First policy, which actually, if it's more efficient and it's actually improving outcomes, sounds like something we should look at across the board, actually, regardless of COVID. But it does seem to deviate from this principle that you shouldn't discharge from hospital until you have a care plan in place. And I just wondered if what the actual technical moment of discharge is, if you're in a kind of virtual home situation, and whether or not we are deviating from that principle that people should have long-term sort of a care plan in place, especially with vulnerable people, before they're taken out of hospital.
Yeah, so I can answer that. Home First is something we've been working on as a system, and Sarah will know all about this as well, because local authority leading a lot of this for the last year and a half. What has been able to be done during COVID is to step that up and increase the number of places, almost double the number of places. And each person is assessed as normal, and if it's possible to send them home with a care package, that's the issue. And the arrangement we have at Home First now enables people who still have COVID to go home with a package with the arrangement through GHC. So that is really good for people, because they actually get back to their place and get support, are able to self-isolate, and if they need to then go into the virtual ward for further support, they're getting that support. So it is still part of our overall planning for package of care. It's just giving people an extra choice, and we now have more resource stepped up around it. Of course, it does require the domiciliary care in the community to be available, and that's something that we're also working on with the local authority.
Thank you, Mary. Brian Robinson.
Yes, thank you. I'm not sure if I'm asking this in the right place, but we'll see. I was interested in the long COVID, which obviously the longer this goes on, the more we will start to feel some information about. Is long COVID where people continue to remain infected with COVID, or is it that they actually suffer symptoms which are permanent, and therefore they continue to suffer the consequences of COVID, or is it that they can get reinfected? And should people with long COVID be vaccinated? I just wondered really what we were doing. And also, I'm not quite sure how people would identify that they may have these concerns, or if they have this, is it because they've already been in hospital? So are they being monitored that way?
Shall I pick up some of those comments? Long COVID relates to the condition where people have got long-term consequences of catching COVID. So the infectivity isn't an issue, it's the fact that they've got remaining symptoms, which unfortunately with this unpleasant illness is a variety of symptoms, a whole range of symptoms. So that's why you need a multidisciplinary approach to capture management of these symptoms. And there are two ways of picking up these individuals. Some are being referred in via hospital, having been unwell through the hospital system. But increasingly, we'll find people who have been managed in the community and then will be picked up in their general practice with symptoms that may be related to having had COVID and have had a proven COVID positive test in the past. So increasingly, that will be the route through to this service.
I think Eddie.
And in terms of vaccine, yes, absolutely, they should have a vaccine. As long as they've had a 4-week window from catching COVID.
I think Eddie may want to have a word about long COVID. Eddie?
Thank you. I've nothing to add to what Andrew's set out. It's a new service model. I'm sure there's lots of learning still to be had around the treatment and management of long COVID. But the criteria includes for anyone that's been experiencing symptoms 3 months post diagnosis. So I think Andrew's covered all the other key points.
Okay, Brian?
Can I quickly come back, Stephen, just with a question of how many people does this affect? Is it a very minor aspect, or is it quite significant?
I don't have those numbers at hand. I'm certainly happy to go away and see what we've got locally in terms of intelligence around long COVID. But yeah, it's a...
The data I've seen suggests that it could be as many as 1 in 10, but those that have severe disabling symptoms, i.e. the ones that probably access this clinic, it's a fraction of that, thankfully.
Thank you.
I think that Sarah might have wanted to come in. Sarah, did you want to come in?
No, Andy's made my point, thanks.
Thank you.
Do we have
Councillor
any?
Hilton? I think Councillor Hilton wanted to ask a question.
Thank you. I just want to ask, you talk about people that might have long COVID, but at the moment, those who might have had COVID infection, March, April last year, are unable to actually get a test to say whether they had it or not, because you're not able to have an antibody test. And I'll say, on a personal level, that's the problem that I have, because I had the bug sometime last year because my partner had it working in a care home. She's been able to have the antibody test, but I haven't been able to. I'm almost 99% certain. But it is really something I've also mentioned to Sarah Scott before, is that those people were unable to be tested because nobody was testing. Now can't get tested to prove whether they had it or not. And I think it's something that the public health team needs to resolve, because I think there must be other people that don't know whether they had it or not and would actually like to know for their own peace of mind. And if they are suffering from symptoms that might be long COVID because of the recent infection, they ought to know. But you can't do that if you don't get tested for any antibodies at all. So it's wonder why the public health team are not resolving that matter.
I think the reason why we're not resolving it is that it's not within my gift to do that, Jeremy. We have had this discussion, I think, at Scrutiny several times. It's Department of Health and Social Care that roll out the national testing programme. From memory, I think antibody testing was pillar 3, I think, of that particular programme. And it was a limited programme to understand how the disease was rolling through the population. I think the other thing I would say is there's a study that's been published recently called the Siren Study, which looked at the length of immunity, the length of time people had immunity. And they found that I think people had some degree of immunity once they'd had COVID for about 5.5 months, but that was just the length of the study. And it also demonstrated that it is technically possible to get COVID twice. So I understand the anxiety, but I'm sorry, I don't have any access to antibody tests. I've never had any access to antibody tests. It was a national scheme. I think that perhaps, and if you think you're experiencing symptoms of COVID, it's a discussion with your GP, who I'm sure will be really happy to advise. But I don't have any means of rolling that out.
I've added a comment there because I think lots of people, I think you might have used the word, Councillor Hilton, are curious about whether they did or didn't have COVID. But just to clarify, if a clinician believes that antibody testing is of value in diagnosing long COVID, for example, they are at liberty to request that, and the hospital can test for antibodies, but it does have to be requested by a clinician as part of a diagnostic or a management approach, rather than individuals wanting to understand the answer for their own benefit.
And sorry to add to the third part of this conversation, but the point is, as Sarah's quite rightly made, if you probably had COVID back in March, with the taste and the fever and symptoms, I almost certainly had it. You probably won't be recording antibodies now, so that's why we probably wouldn't be testing, and long COVID would be based on the collection of symptoms. But as we've also outlined, since the summer we have been testing, so this issue of not knowing your status should gradually diminish.
Thank you. Do we have any more questions?
I can't see any hands raised, Chair. I think that's the end of that item.
Thank you, Eddie.
Chair.
Pam Tracy.
Yeah, with Co, I suggest that, Jer, if he's worried, I shan't be speaking to you in the street again now. But no, I wish you luck, Jer. And if you're that desperate at the moment, I would go and see what you can do.
I'm not worried for myself, Chair. I'm just worried for the fact that there must be other people that aren't as robust as I am, that would have been worried by it. And it just seems that in public health terms, it seems ridiculous that at the time that a lot of people had the infection, they didn't get the normal tests, and that when the antibody tests were available, the public health team or the National Health Service didn't offer that test to people. If you work in certain sectors, you did get it. I'm just saying that some people didn't get it, and therefore it's an inequality that I'm raising, what might be the case for a load of other people who are in the same situation. It's not been resolved to satisfaction, I think, of many people.
So, Jeremy, is the doctor got it now?
No, I haven't got it now.
I think just to wrap up, because I think the most important point is the one that probably Andy made, that hindsight is a wonderful thing, and whilst it would undoubtedly have been beneficial to have had more testing at the time has now passed to go back retrospectively, because Andy said antibody levels wane over time, so it would be a largely unreliable test if we were to go back and do all those individuals that had COVID back in March and April.
Yep. Can we now progress on to number 7? Ian,
I'd just like to say that I think the reports that we've received this morning, the written reports from the Health Service, from Sarah Scott, have been really impressive work, and they come at such an important point when Sarah has indicated that perhaps we are at something of a tipping point. But what has been input this morning, I think, shouldn't be lost. I think I'd like to propose through our joint chairs that they form the starting point for a comprehensive, for the record, account of how Gloucestershire responded and is responding to the crisis. I'm sure there'll be things to celebrate in such a report. I mean, for example, the vaccination programme has been phenomenal, but there will also be lessons to be learned, and all of this should be captured. So can I propose, as members of the Health and Care Scrutiny Committees, that we call for Gloucestershire County Council to take the lead in coordinating the production of such an account, a comprehensive account, together with the NHS in due course?
Do you know, Ian, that has been going through my mind this morning. Did anyone wish to second that? If no one does, I will second that. Or Martin will second that.
Chair, can I just note also that the NHS colleagues, or in fact One Gloucestershire, did produce a kind of what I think we called our silver linings, but a lessons learned report at the end of the first wave. So as an interim piece of information that might be of interest, I'm sure we could share that with you.
Yeah, that would be great. Are we all happy that we do seriously look at producing almost a ledger of what's happened since day one?
I thought we were in the process of doing that, but yes, absolutely, yeah.
I think Councillor, just have to caveat that with obviously the timing of it and amount of time that we could give from the NHS in particularly clinical colleagues' time, because even when we're through the acute pandemic phase, we have an agenda of recovery that you could only begin to imagine, and that's years ahead. So I just do a plea that we tie this in with the inevitable regional and public inquiries that will also look into NHS and social care and local authorities' handling of the pandemic, so we're not duplicating work. I think we could start something that's laudable and it could get overtaken. So perhaps we could just all kind of tie that together, please.
Yeah, and Mary's also put a comment there. Mary, you said.
Yes, I suppose I would echo Deborah's point about silver linings. The first thing we want to do is to pick up the areas where we've learned really good practice, and we want to build on that first. Maybe if that was our first phase, we'd be up for that, certainly, because we've talked about that in the last week, some things, and then maybe add to that as we go forward. Certainly the partnership working has been beyond comparison, so that's another area we could easily pick up on. And of course, we're building on that with our volunteering approach, which is about to be announced in Gloucestershire. So there's some things we certainly could pull together into a briefing. Maybe if people identify the kind of areas they're interested in, we could just test about which areas we do first and then work on that first.
Yeah. I think, Mary, didn't we have a CQC review of our response to the pandemic as a whole system as well that was published?
A lot of work is already being done, and the reports today are part of that. But that's why I also said in due course. I appreciate that we're in the middle of a pandemic and that people are under a lot of pressure.
Yeah.
But, and that's why I also suggest, may I say so, that the County Council perhaps takes the lead in bringing it together in due course. But thank you, Stephen, for picking that up, and I'm sure that will be noted for the record. Thank you.
If it would help, Chair and members of the committees, for the briefings that we've had throughout the past year, we could log the briefings and date them as we've gone forward into one document, that we could keep a record of what the two committees have been advised and updated on as a committee record. So I'm happy to do that if that would help to have a log.
Yeah, absolutely.
Thank you. Can I now draw us forward to items? I think we'll take number 7 and number 8 together, which is Public Health Report and Adult Social Care Report. Are you happy with that, Sarah?
So these are just for information. So they're just update reports from a public health and adult social care perspective. I've kept them separate. I'm really conscious of some of the feedback from members around the proposal to merge my post with Margaret's DAS post. So to ensure that public health continues to get the right amount of scrutiny and attention, I'll continue to keep the report separate to make sure that everyone is fully updated on what's going on. So I'm happy to take any questions.
As you wish. Questions following Sarah's public health report.
Councillor Martin Hall, I believe your hand is raised.
Yeah, thanks. Thanks for the report, Sarah. And I'm just really interested in the HIV section, actually. And I just wondered how much that is the potential for prophylaxis is being coordinated with LGBT groups in the community, and charities like Terence Higgins Trust and others with a lot of experience with high-risk groups or higher risk groups.
We have a provider, loosely termed our sexual health prevention provider, who is the organisation that we've commissioned to work with groups at higher risk of adverse sexual health, of poor sexual health. So it's not the Terence Higgins Trust; it's a different organisation. So we're working through them at the moment to make sure this is promoted. But we are doing it. We're just doing it through our commission provider and also through the service. So this is a Gloucestershire Health and Care provided sexual health service. So we're also working with them to make sure it's promoted in the right way with the people who are most likely to benefit from it.
Sorry, can I just come back on that briefly? I mean, I wasn't really asking about who's providing the service. I mean,
it's about who is promoting it. Who is promoting it with the at-risk groups? So we've got a way of doing that. So the way of doing that is through our provider, and they're the ones that provide all of our support to the LGBT community around their sexual health. So it makes sense that we ask them to promote PrEP as well.
So, but the specific question was: are they coordinating with groups, for instance, like the Cheltenham LGBT Partnership?
There should be. I can check. I don't know the detail of it, but I can certainly go and check.
Sure, thank you.
Thank you, Sarah. Any more questions? Don't think so.
Yeah.
Councillor Hodgkinson has his hand raised, Chairman.
Thank you.
Paul, sorry.
Thanks, Stephen. Yeah, no, I just wanted to thank you for the report. I'm really pleased about the availability of PrEP now through the NHS. I mean, that's a brilliant move, a real step in the right direction. I wanted to ask generally about sexual health, and given the crisis and lockdowns, etc., you might expect the incidence of STIs to have dropped quite a lot during that time. Is there any evidence to support that? Are there any figures available that trend has gone down during the last year or so?
We certainly do have the data. I don't have it in front of me to give you an answer, but what I could do is provide an update on sexual health services in my next report for scrutiny. Very happy to do that. I know that we've seen, for example, in primary care, decrease in attendance for some of the sexual health services commissioned from primary care, but that is more around the service rather than the need within the community. So we can provide an update at the next scrutiny if that's helpful.
Yes, thank you. It would be. All right, thank you. Can we now proceed, Sarah, on to your adult social care report?
Again, this is a report for information, so I'm happy to take any questions that the committee members might have.
Councillor Martin Horwood, would you like to ask a question? I see your hand is raised.
Beg your pardon, my fault. I hadn't lowered my hand. No, I don't have a question.
Sorry, just checking. Thanks.
Thanks.
Brian, you're waving.
Yeah, I have a question. I'm not sure if I'm next in the queue, but if I am, I'll carry on, shall I?
Yes, please.
Okay. Yeah, my question under adult social care, obviously we're delivering a lot of care in the home. I just wondered how we were coping from a staff point of view in delivering that support during the COVID crisis, but also whether there's any additional pressures on staff coming from other the other changes that are coming about through Brexit and the rest of it, whether that put any additional pressures onto the adult care workforce.
I think we are obviously exceptionally busy, and the work we talked about in terms of how to get people out of hospital and assess them adequately happens a lot in our social care sector. So we move people out into what we call discharge to assess beds, and that obviously does need a social care workforce to do those assessments and make sure that we can commission those packages of care. So the team are exceptionally busy. We've not picked up any immediate problems as a result of Brexit, but we have had quite a long time to plan for this. And the team had done an awful lot around making sure that we understood where our workforce was coming from and what we could do to stabilise it. So there's no particular issues at the moment that I'm aware of.
Thank you.
Thank you. Brian, are you still waving, or are you? No, thank you. Does anyone else have a question of Sarah and the adult social care report? Sounds like not. Thank you, Sarah. Thank you. I think we'll take a 5-minute breather here, maybe, before we go on to non-health subjects. We've got the Chief Fire Officer's report and the Road Safety Cabinet Panel report. And we'll do that at about 12:10.
Chair, the report, as Sarah stated, is for information only, but I would like to draw members' attention to a couple of aspects in there. We focused the report this time, as per the request to Sarah, on particularly on the response to COVID and the work that's been done. So happy to take questions on the list of activity that is quite comprehensive there in comparison to many other fire and rescue services. But at the time of writing this report, we got a HMI CFRS, so the inspectorate had issued an embargoed report, so we couldn't write about it in this report. But since then, that's obviously been published, which actually identifies the good work that has been undertaken in Gloucestershire by Fire and Rescue in support of public health, the NHS, and social care, and a variety of other partners. So really proud and pleased to see the amount of work and the amount of support that's been undertaken by Fire and Rescue, and that they've been able to provide in response to COVID across Gloucestershire for the communities. So that's nice, makes a nice change to get some good news. Couple of other issues that again have arisen since the report was written. So we've heard a very comprehensive update on the vaccination programme. Some fire and rescue services across England are providing fire and rescue staff either as vaccinators or to support the logistics and the running of vaccination centres. So again, that is something that in Gloucestershire we would consider if that was required and would respond to that request. Quite interestingly as well, some fire and rescue services have actually now got fire and rescue service staff working in acute hospitals to free up medically trained clinicians and hospital porters who are carrying out an activity called proning, which is about moving patients, and again, doesn't necessarily require the clinically qualified staff who rightly could be freed up to do other work. So, you know, that's not something we're doing in Gloucestershire at this stage, but again, it's just an idea of some of the areas that fire and rescue services are getting involved in. And again, I'm sure with the number of volunteers that we've got in Gloucestershire, should that support be required, we'd respond to that request locally. And then additionally, the final point is lateral flow testing. Obviously, fire and rescue service staff, where they come into contact with somebody who's had a positive COVID test, are required to isolate, and with obviously the need to maintain the availability of the workforce to respond to emergencies and support the response to COVID. The aim is to try and get those staff back to work as quickly as possible. So the Home Office has secured some 60,000 lateral flow device tests that have been distributed amongst fire and rescue services across England. So we will be working with the local public health team to take the right advice to make sure we develop a process to rapid test staff to try and minimise the amount of time they're absent from the workplace to maintain our availability. The rest of the report is there for members to see, and I'm happy to take questions if anybody has any. Thank you.
Does anyone have any questions for Wayne?
I have Councillor Lydon, Councillor Parsons and Councillor Hilton with
Yes.
raised hands at the moment.
Councillor Lydon pre-booked a slot, didn't he? Yeah. Okay, Councillor Lydon.
Okay, thank you very much, and thanks for the brevity of the report. It's with reference to talking about COVID and fire services. There's a recent HMI report, a national one, so I presume it's just for England, was done where it very much criticises the fire brigade union and their attitude, reference, perspective on safeguarding the staff and activities relating to COVID. I'm led to believe that the FBU weren't even consulted on this report. So I just wonder if you could give us your perspective, what's happening in Gloucestershire, what's your view on that report? And certainly, my understanding is that firefighters are locally playing a key role. And these sorts of reports don't, I think, help you or help us in terms of confidence. But appreciate your perspective on that HMI report.
Thank you very much, Councillor Lydon. My perspective on the HMI report is that the HMI CFRS pride themselves on factual and evidence-based objective reports. But I suppose any challenges to the accuracy of that report and whether or not the Fire Brigades Union nationally were consulted on that report are a matter for the HMI CFRS. I have seen a press statement and heard a national interview that involved the General Secretary of the FBU and the Fire and Rescue Service Lead Inspector. That indeed the Fire Brigades Union did have that report shared with them before it was released. But again, the accuracy of that is a matter for those two individuals. What I'm more interested in, and what I'm very pleased to say, is that there is quite clearly tension at a national level between the Fire Brigades Union, the National Joint Council, which is a national committee of employers for the fire and rescue sector, and in some cases the National Fire Chiefs Council. However, that tension is not something we are witnessing or seeing locally. We have worked really hard to maintain very positive industrial relations with all the trade unions, including the Fire Brigades Union locally. We are in regular dialogue with them. We consult with them. And the most important thing is that I think the challenge and the concern is around risk assessments for undertaking activity safely. Regardless of any tensions nationally, I am ultimately responsible for the risk assessments for my staff and what we ask them to do. And the Fire Brigades Union or the National Fire Chiefs Council or the NJC cannot, and I'm sure would not, accept responsibility if something went wrong. And staff welfare and well-being is my absolute top priority. And being responsible for the local risk assessments we take that very seriously, and we've made sure that we have full risk assessments in place for every activity we undertake locally, because legally I am accountable for that, and we've made sure that is the case. So it's unfortunate, but it's not affecting how we perform locally. And you're right to acknowledge we've asked staff to volunteer, so staff are volunteering for this work. We've protected staff's terms and condition in relation to the work that they're undertaking, and we've made sure we've got very comprehensive welfare arrangements in place, which has been acknowledged by the HMI in the local Gloucestershire report. And importantly, we've maintained very positive industrial relations locally as well.
Well, thank you very much. I'm very pleased to hear that locally things are progressing. Very much appreciate your answer.
And the question...
Councillor Parsons, Councillor Hilton and Councillor Steve Robinson, Chairman.
Thank you, Wayne, and a really excellent, first-rate report from HMI. The one point which I'd have arising from it, they don't seem to recognise, and I maybe could comment on this, that possibly the excellent working which you have with the County Council and with the NHS might come from the structure which we have in Gloucestershire, which is not true of all, which is only true of a minority of fire services, where you are actually you are sponsored directly by the County Council. I don't know if this is a point which they picked up, or in fact it's just a point which they haven't recognised, which I think is very important.
Thank you, Councillor Parsons. They've not specifically referenced it in Gloucestershire's letter, but they have a cover letter, which is the national response, which summarises the 45 inspections they did. And in that national response, they do acknowledge that County Council Fire and Rescue Services appear to have been better placed to respond more quickly and in a less inhibited way than other governance models. So there is a reference in the national report.
Very encouraging. Thank you very much.
Councillor Robinson.
Oh, sorry, I think it's me next.
You're right, Jeremy. I forgot to write your initials on the sheet.
Yeah.
Fire away.
Thank you. And thanks, Wayne, for the report. I'll just say congratulations to everybody that works for Gloucestershire Fire and Rescue Service for the work we've done during this pandemic. We were very proud of the work that the Fire and Rescue Service did in 2007, dealing with the floods, which were, and I think we're just as pleased and with the work that the Fire and Rescue Service has done during the COVID-19 pandemic. I'm interested that the HMI inspector appears to suggest that the performance of fire and rescue services in assisting others during the pandemic has been better in county council fire services. That's something that I thought would quite clearly be the case. So one of the questions that might go to Dave Norman. What's the latest status on Martin Sewell's attempt to of his hostile takeover of Gloucestershire Fire and Rescue Service? And two, what's the latest information coming out of government about that? Other question, more to Wayne, fire incidents and road traffic accidents, how have they changed? Have they gone up or have they gone down whilst people stay at home? I would have thought, my gut feeling, without knowing the answer, is that fire incidents and road traffic accidents have dropped, but I'd be interested to know what the situation is.
Do you want me to go first, Wayne, or do you want to follow on with the incidents and then I'll round it up? Silence must mean that he wants me to go first.
Must be. He's on top of the hill, of course.
In response to Councillor Hilton's question, where are we with it? I think the Police and Crime Commissioner still has a very, very strongly held view that he would be better than the County Council at governing the Fire and Rescue Service, and sits in the background waiting for the outcome of the role of police and crime commissioners and their work going forward, which obviously can include taking on the responsibility of fire as well as police and crime. Clearly, I think we are well positioned, as we were in his attempts before to take on the governance of the Fire and Rescue Service. I think we are well prepared to mount any challenge that the government might bring in respect of that move. Both Wayne and I were on a call yesterday with the Fire Minister present. It's very interesting that the comment that has been made by HMICFRS in respect of county council services, and maybe they are better suited to work within communities than other governance models. We wait to see. I'm well armed, as are colleagues in and around the authority, to make a very robust challenge. The last we heard was the decision would be taken after the PCC elections, which obviously are due in May. But whatever decision is taken, I believe this will go on for a little while before there's a final outcome. But don't be concerned, Jeremy. We will fight this right to the top of the hill and down the other side.
Thank you, Councillor Norman. Councillor Robinson.
Sorry, Stephen, Chair. I did ask Wayne about what the changes are in road traffic accidents, fire incidents, and I haven't had an answer.
Thank you, Councillor Hilton. Very briefly, during the first lockdown, we saw a significant decrease in incidents, but if you think about the time of year that occurred, then I think it's different, obviously, than the lockdown through winter. So we saw up to a 40% reduction in fires and about a 30% reduction in road traffic collisions. That then began to increase as traffic started to move again. What we saw with road traffic collisions was a smaller volume and number because of fewer people moving about, but an increase in severity because of the speed that vehicles were travelling at because the roads were quiet. We haven't seen those numbers then return to normal as soon as lockdown was lifted. So we had a gradual return in the number of fires and a more rapid return in the number of road traffic collisions to what we would expect to be normal levels. During this lockdown, we haven't seen the same reduction in road traffic collisions, but I think that's seasonal. And obviously it's early days as well to get the figures through, but we are seeing a reduction in the number of domestic property fires. But again, it's early days because we're only a few weeks into the first lockdown and the figures lag slightly. Thank you.
I mean, the roads are a lot busier in this lockdown than they were in the first lockdown. Yeah, I can see that with my own eyes. I go out and take the dog for a walk, you know, the roads are busy, a lot of people driving around. So I can see these figures suggest what it is the case, that maybe people staying at home is helping reduce the number of household fires, which is good news anyway.
Yes, thank you, Wayne. Thank you, Jeremy. Councillor Robinson.
Yeah, thank you, Chair. And thank you very much for your report, Wayne, and thank you for what the service has done in stepping in and working with other agencies. It's great to see that. I would like to just ask, as a member of the Police and Crime panel, we were told last week that quite a lot of officers were not retiring early, perhaps because of the current situation and perhaps nothing to move on to. And I see the ad in for new firefighters. Have you found this, that some officers are not retiring as early as was first thought, and we're keeping them a little bit longer because of the pandemic?
Thank you, Councillor Robinson. Not really, no. We're not following the same trend that the police are following, and I think the context is quite different. So I do have a couple of anecdotal examples of where staff have said, I can't retire at the minute because there's too much to do, or I'm involved in X, Y, or Z, and I don't want to stop being involved in it. But that is only on a couple of occasions. One of the things that I've focused on and seen, unfortunately, since my arrival, and it's probably some of the improvement journey work that we're doing, is that quite a high number of staff retire early from Gloucestershire Fire and Rescue Service, which I think is an indication of some of the cultural issues that we've been trying to work on. And unfortunately, for operational roles, we still do see that, a higher proportion here than I would suggest in other areas, which is something we're looking at getting to the bottom of. The reason we're out recruiting at the moment is because of the normal natural turnover within the workforce plan of staff. But what we do have to account for within Gloucestershire Fire and Rescue Service is that staff do tend to retire with between 25 and 30 years service, when normally you wouldn't expect them to go until they've done at least 30 years. So that turnover rate is probably slightly higher than we'd expect for a service of the size of Gloucestershire. But the pandemic's having a minimal impact, really.
Yeah. Thank you for that, and thank you for your insight into, I wasn't aware, and perhaps others aren't aware, that, of the culture. Well, we're aware of the back culture, but aware of people wishing to leave because of ongoing, stressful times, maybe. But perhaps we could drill down a little bit more about that at some other time, Chair, how things are going regarding that. Thank you.
Surely. Does anyone else have any more questions for Wayne? Thank you, Wayne.
Councillor Terry Hale, I believe, Chairman.
Councillor Hale.
Thank you, Chair. Thank you, Wayne. Can you tell me how many of the fire service personnel has been vaccinated? Because we had a SWAS report, and I think it was 87% of their force. Some refused to have the vaccination through either, allergic reactions and so on. What has happened in the fire service?
Thank you, Councillor Hale. I don't have the exact numbers in front of me, Councillor Hale, but in terms of fire and rescue staff who are supporting South West Ambulance Service, all staff who do crew ambulances are offered the same level of PPE protection, including the vaccination programme, as the ambulance service staff. So we've got approximately 30 staff supporting South West Ambulance Service on various shifts. They will all have been offered the vaccine, but I'll have to come back to you and provide the information on the exact number of the uptake. And as we discussed earlier in the vaccination item and in the chat bar at the side, firefighters are not in the first 9 categories of people to be vaccinated, which is a national policy review position. So we await the outcome of that to see whether other fire and rescue service staff who aren't volunteering for ambulance duties will get vaccinated in due course.
Thank you very much. Thank you.
Thank you. Does anyone else have another question for Chief Officer Bocock?
Councillor Brian Tipper, Chairman.
Thank you. Councillor Tipper.
All I can say is that quite a few years ago now, the effects of the relationship of pensions and sick pay and that sort of thing was looked at quite deeply. That was about 5-6 years ago, and the report that was issued got national recognition by memory. So anyway, whether anything could be gained by re-looking at that, I don't know. But perhaps it might be a good thing to look back and see what was said.
Thank you. Thank you. Any more for any more? Seems that we have exhausted your questioning. Wayne, before you depart, will you please express the thanks of this scrutiny committee to every member of your staff for going over and above the normal level of activity and duty which we expect of the fire service. Without them, we wouldn't be in the good position where we are in offering added services to our population in Gloucestershire. So thank you very, very much indeed.
Thank you, Councillor Hurst. I'll pass that on.
Thank you. Thank you. Now we come on to, I think, item number 10, the Road Safety Cabinet Panel. And we have a report from Councillor Norman to present this report, which includes some recommendations from the Road Safety Cabinet Panel review.
Thank you, Chair. It is, as you will have noticed, a very long report, and to try and keep it shorter, I actually have left some of the commentary out, and I will use it as my introduction to the paper. You will note that the paper goes onwards to Cabinet in March. I must start, Chair, by thanking my Cabinet panel colleagues who've listened to the evidence on road safety within Gloucestershire, enabling us to reach the recommendations that are contained in the report that all members on this call will have read. Furthermore, Chair, on behalf of the panel, to thank all those who provided us with the data, information and visions they hold for improving road safety. I should also like to note the support and professionalism afforded me by Laura Powick from our DSU team. Evidence gathering was primarily through presentations backed up by exemplars from other local authorities and successful collaborative schemes established nationwide. The report and the appendices contain a great deal of information. We hope that members found that both informative and useful. The panel quickly realised that a more coordinated approach to road safety across the county is required. Members will note that comments to back up that opinion are spread across the report. The fundamental question has been, how can we together bring those with a statutory responsibility, councillors, volunteer and interested groups, charitable trusts and our residents into a workable structure that will develop safer roads for all our users. One panel member is keen that where district road safety groups remain active, they should receive support. Moving forward, we need to ensure that parties who have a proactive view on road safety should be given every opportunity to be heard. Local knowledge is invaluable and should always be considered. Recently, a paper jointly written by a principal officer from the Fire and Rescue Service with a senior police officer was delivered to the Safer Gloucestershire Board. The paper received positive feedback, generated conversations of how partners could actively engage with a consultative approach to road safety. And on the back of that, road safety has been approved to be an inclusion as a strategic priority for that board. Before moving to the recommendations, I wish to highlight the costs of road traffic collisions and why it is vital that we accept the need for shared funding of road safety, primarily driven by the statutory authorities, supported where possible by other partners who want to work within this arena. Every incident on our road costs. A fatal road traffic collision, the estimated cost of the public purse is 2.26 million. A serious injury incident, an estimated cost of 262,000. A slight injury incident, an estimated cost of 26,000. So in Gloucestershire, taking a 5-year average, the cost of killed and seriously injured equates to 24 fatalities at a cost of 2.26 million, plus 265 serious injuries at a cost of 262,000 per injury. I'll leave you to do the maths. I haven't included slight injury or damage only costs. It is also estimated, Chair, that every unreported incident could add as much as 116% to the cost of reported incidents? But more crucially, how many unreported locality incidents could be the next killed or seriously injured statistic with further costs? The presentation delivered to the panel by Nigel Lloyd-Jones, in which he spoke passionately about a Gloucestershire Vision Zero to be achieved by 2040, with a 50% reduction in killed and seriously injured data by 2030. This is a real challenging target and will only be achieved through a collective approach of engineering, enforcement, education, and engagement. To have any chance, we must accept that none of the above will achieve success in isolation, and that maybe a Senate and forum approach to road safety in Gloucestershire is the way forward. I hear you thinking, Chairman, a Norman learning from the Romans. The Senate is to be made up of officers from GCC, including the Fire and Rescue Service, the Constabulary, the Police and Crime Commissioner or his nominated representative, and I would suggest a cabinet member responsible for road safety. Designated officer report will be required and is referenced in the recommendations to the report. The forum is a vehicle of engagement, providing the opportunity for elected members, road safety groups, and others interested in road safety, including residents, to bring their concerns and requests for debate and discussion. The outcome of any discussion will then be forwarded to the Senate. The forum will be chaired by the officer highlighted. Chair, moving to the recommendations. Each one of them has been fully debated both within the panel meetings and through other opportunities afforded me as chair of the panel during the last year. I want to highlight one extra thought though, Chair. Proposals for any road safety changes must always be data-led. As members of the local authority that has a statutory responsibility for road safety, the panel looks for all member support as this report moves forward with those recommendations highlighted that just could make a difference to the residents we represent. Thank you, Chair. I do apologise for the length of the report. I do apologise for taking this opportunity to make some comments to back it up. The road down which we wish to drive, sorry about the pun, is going to be challenging. Vision Zero is going to be challenging, but we have to start, we have to believe, and in that timeline, I believe we can make a significant difference. Thank you, Chair.
Thank you, Councillor Norman, or is it Councillor Norman Roman?
I think members need to be aware that the report will be presented, I believe, to Cabinet on the 24th of March. Any comments from this meeting will be fed into that meeting to help Cabinet form their decision.
It does say the report to be noted. Does that
any comments, Chairman? With any comments, they would be fed into the report process.
Does anyone have any comment on the road safety report, which has been very expertly put together, I must say?
I have one, if I can come in, Chairman.
Yes, Councillor Robinson. Then we have Councillor Tipper.
Thank you,
Brian.
Okay, I'll go first. Obviously the ambition to achieve zero casualties by 2040 is really good, but that's nearly 20 years away, and I think we ought to have some interim steps on the way to allow some early wins to be built into the work. It's quite possible by 2040 that we've taken the driver out of the vehicle, which may well actually be the biggest step we could make, but it's a long way off for us. In the short term, we've still got drivers in the vehicle, and that's probably going to be the biggest cause of accidents. But we've got education on our list of things we want to do, and I would have thought that a significant step on the journey to zero could be achieved earlier by a significant education program. It's unfortunately the case that you have to keep repeating the education, partly because we get new drivers come along, but we do tend to forget things once they go out of top of mind. So I feel that the report would benefit from having some interim steps on its journey, and perhaps to focus education in the early part of that journey, when other things may well come in longer term.
Chairman, before we go any further, I can note that Councillor Paul Hodgkinson, Colette Finnegan, Brian Tipper wish to also comment. So I'm in due course, and Councillor Hilton. So in due course, I'm sure that you'll be brought in there. Thank you.
Can you repeat those people again, please, Joe?
Councillor Paul Hodgkinson, Colette Finnegan, Jeremy Hilton, and I believe Brian Tipper. And I will let you know if there are any other members who wish to speak.
Okay, thank you.
Chairman, if I can respond to what Councillor Robinson just said.
Surely, yeah.
If he notes in the report, yes, 2040 is a long way off, but there is a comment in there that we'd like to reduce that by 50% by 2030. So if you take last year's figures, where there were 24 fatalities, our aim will be to get it down to 12 by 2030. I do take the point around the fact that the world is going to change in respect of the type of vehicles on the road, maybe even the number of vehicles on the road if we can encourage more people to use public transport. But at the end of the day, education has been there for as long as I was serving operationally in Gloucestershire Fire and Rescue Service. We were one of the first services to actually establish education with the most targeted differential problems in respect of road traffic collisions, and that was in the 16 to 24 age group. The education needs to and will continue with that age group, but sad to say, 37% of the road traffic collisions in Gloucestershire over the last 2-year average has been in the older age range of drivers. So what we've got to do now is expand the education. I'm already in discussion through the Fire and Rescue Service with ways in which we can educate older drivers for them to understand that they have to, at times, think a little bit more before they do the actions that they perform on the highway. But I do take Councillor Robinson's points. We'll take them forward. We'll try and achieve a lot more once we establish what we are going to do through this coordinated approach. There will be a lot more that will come out over the next 12 to 24 months.
Thank you. Councillor Hodgkinson, please.
Yeah, thanks, Dave, for taking it serious. Road safety is clearly a very, very important issue for all the reasons you've stated. I'm glad that you, in the recommendations, referred to the TRO process, because for me as a councillor, it's the TRO process which really is so frustrating, not just for me, I think, but the parish councils, residents, town councils, the sheer length of time it's taking to get things in place. As an example, something took 4 years to get in place in one of the villages I represent. That's a long time. And it was all to do with the TRO officers being so overworked. I mean, they clearly were, and they had so many conflicting priorities. So it's a plea for you to make sure that that is really on your radar, the Cabinet's radar, to try and speed things up a bit within the TRO process, and look at the staffing as well, which seems to be too few at the moment. Thank you.
Thank you, Councillor Hodgkinson.
Yes, Councillor, I can clearly confirm that it came through the panel's discussions from the first meeting right the way through to the last, that the TRO process does need a lot of injections into it. You know, sorry about the pun, talking about COVID and injections, but it clearly does. And one of the things that I've taken on board is lobbying the 6 MPs in Gloucestershire to actually put in the hands of government in Westminster to get them to move forward on their promised review of the TRO process nationwide. They've agreed apparently in Westminster that it's due for an overhaul. We will actually put something into that process when the time is right in respect of staffing, If we believe, and obviously I will take advice from officers, if we believe we need to enhance that team, then obviously I will look to gain the funding for that to happen. But your points are well made, and I do support them fully.
Thank you. Are you happy with that, Councillor Hodgkinson? Thank you. Councillor Finnegan, please.
Thank you, Chair. It's for Dave, obviously. Dave, excellent report. There are a few things I'd like to ask you, please. You have your panel, your road safety panel, top 3 safety concerns. None of them actually talked about the e-bike, the e-scooter, which I think is a huge concern. Basically, we haven't had a lot of them being used at the moment because the young people who would be using them, I dare say, are not on the streets and not vacating the pubs. When the pubs were open, they were being used when pubs closed, and they weren't being used properly. The chap who owns these bikes, Zoe Dwing, I believe his name is, says that they should be over 16 because they are considered a public light vehicle and a helmet should be used. Where do you suggest you get these helmets? And as we know, the helmets were not being used, and they were being used inappropriately all down King Square, etc., when they're supposed to be used on the road, and they're actually a public nuisance. But there's nothing in your report about this, which is quite bothering when a lot of cities started these trials and have actually now not taken this up. So a little bit of information on that would be nice. Thank you.
Thank you, Councillor Finnegan. Nothing actually came up in the panel in respect of e-scooters or e-bikes, and I'm guessing because it was something that when we started the panel, and we have to remember that that was 15 months ago, COVID stopped us doing anything between March and October. There was no discussion around e-scooters or e-bikes at all. However, I know there has been one incident in Gloucester involving 2 ladies who were inappropriately using an e-scooter, having come out of a hostelry. I believe they may have been inebriated, but I'm not 100% sure. But clearly we can add anything. And if you want to put that in writing to me, I'm very happy to add any suggestions to the recommendations that we've got forward. But of course, the e-scooter and e-bike, I believe, is a trial. I believe it will continue. But I do take your point that if there is concern about them and they need a lot more investigation into the use of them on our pedestrian areas, then I'll certainly look at it and get back to you with a response.
Thank you very much. Thank you.
Councillor Hilton.
Thank you, Chair, and thanks to the panel for the work they've done in putting forward these recommendations, which I'm happy to endorse. Following on from what Paul Hodgkinson said about the TRO process, that is something that we really do need to get to grips with. Dave Norman will know my frustrations about just getting the parking review in Kingsholm and getting a whole load of applications into WR lines put into the system where we can actually get out to consultation. And we know that the staff that are dealing with traffic regulation orders are overwhelmed and it just do not have the resources in order to process them. So we're trying to process them for parking issues, but we might well need to do it also for road safety reasons. So if we're going to do this, we're going to need to look to increase the budget that's available and the number of staff that are working on it. I don't know whether Dave Norman's planning to do that. The other one is establish a meeting of all county councillors within each district authority area, supported by an officer. Can I say the old city estimates meetings, which were disbanded by this administration, I always welcomed and I always attended. I thought they were really very useful, mostly about highway maintenance issues. But I do think they're a good idea when we're looking at traffic road safety, and I'm sure that all members of the who represent Gloucester City will be happy to meet to discuss issues that are needed to be discussed. I think we probably need to have a budget for road safety works, and I think we need to be a bit more flexible than the officers' suggestions we get back when you can't do something. It's all data-led. I'm sorry. Though you've got people speeding down your road, there aren't enough of them in any 1 hour to introduce things like a variable speed sign, which is a problem I'm getting in Sanders Lane. The data proves that people are speeding. The data says there's not enough people driving down the road to warrant doing anything about it. So that's an example of, and I think it will be really helpful to get members post-COVID round a table that represent the City of Gloucester to look at areas within their division and across the city which we believe to be road safety hazards, and try and come forward with recommendations that we can put forward collectively to officers to say, please resolve this and get this problem sorted. I think when members are doing it on their own, sometimes it's really difficult and you just get fobbed off by officers saying, oh, doesn't meet the data requirements, oh, we haven't got a budget for this. And there's no outlet really for a member to bring in colleagues from around the city and say, can you support me on this? I'm sure Pam has the same problem and others have the same problem to represent the city. Yeah, and it's the same, because in Gloucester, for example, we have intimate knowledge of each other's divisions. It might be more difficult in rural areas where people don't necessarily know intimately the problems in that patch. But I do think it's a good idea, and I hope it goes ahead. It will need resources, and frankly, it probably needs a budget allocated to an area so that some things can be done which aren't necessarily planned.
I think there's a question in there somewhere. I do take the point that you've made, Jeremy. You're very good at making points, a lot of which have been considered and discussed. And where we are at the minute, I'm not going to say any more on TROs because your group colleague raised the point. I actually made a response to your group colleague, which is no different whether you're in the Cotswold district or whether you're in Gloucester City district. If there is a need for more officers to look at TROs, and that point has been made, I've told you what I'm going to do in respect of pushing this forward upstairs to Westminster, where we get officers coming to me as a cabinet member and say, we need to consider the budget to get more staff into the TRO process. I will clearly look at it. You will also be interested to know that the comment about establishing district group meetings of county councillors again came from one of your group colleagues who was very keen to see that to happen. I believe it can happen across all 6 district authorities, but conversely, he did not agree with the view that there needed to be separate budgets for each of those district authorities. His view was very clear that once you actually establish the process of a Senate and a forum where the provisions are brought forward and discussed, then it becomes a county issue, and each one of those district groups of county councillors will meet, will establish the priorities, they will go through the process, go onwards and upwards to the Senate, if that's what we adopt, and if there is a need, it will be addressed. So clearly, I'm on the same page as you, Jeremy. I'm clearly happy to push all of these procedures forward and the process forward. And obviously at Cabinet, I'm sure you'll ask me the similar questions again at Cabinet, and I'll do my best to get it through.
Thank you, Chair. And thanks for the compliment, Dave. And you're usually quite good at answering the questions as well. In order to carry out improvements to our roads anywhere in the county to deal with road traffic issues, it's most likely that we're going to need financial resources put behind it to carry out on the ground works. So there will need to be a budget, even if it's a global budget across the whole of the county. There will need to be a budget where, you know, members in a group might have to make a decision on which ones they recommend to go forward, and there might be a number of them, but officers will say, we haven't got the money to do all those, you can't have all those. So I think it's important that we look at that, and that's something that is closely watched annually when we are setting the budget of the county council, that we have the resources to actually carry out the improvements to our roads to make them safer.
Okay, thank you. Point taken.
Can I just say that we've got a number of questions to come back to. We've got Brian Tipper, I believe. We've got Martin Horwood, Sean Parsons, Dilys Neal, and I believe Steve Robinson. I hope you've got that in order.
Councillor Tipper is...
I did put my hand up too.
Councillor Tracy.
Just very quickly.
Can I repeat them again, Chairman, or are you okay with that?
Horwood, Steve, Sean Parsons, Brian Tipper, and I've missed one out somewhere.
Councillor Steve Robinson and Councillor Pam Tracy.
Yeah, thank you.
Sorry, Chair, I didn't lower my hand last time. Don't include me.
Well, go on.
And Councillor Dilys Neal, Chairman. Have you got Dilys there?
No, we'll replace Steve with Dilys.
Chair, just to finish off my debate with Councillor Hilton, clearly it shows within that Cabinet panel paper that a budget is required, and the statutory authorities would need to lead on that.
Thank you. We can't do it for help, can you? We now have Martin Horwood.
Thanks, Chair. And I'd like to thank Councillor Norman for his report. I realise I'm a little off-piste as a HOSC member asking about this, but I just wanted to commend something which I know is supported currently by the Police and Crime Commissioner, which is called the Under-17 Car Club. It used to operate at Cheltenham Racecourse, but now I think the closest venue is the Three Counties Showground at Malvern. It's an astonishing programme. The statistics show that kids who participate in it are 3 times less likely to have an accident when they become new drivers and eventually pass their test, which is an incredible statistic. I mean, I think it ought to be compulsory, frankly. But I do want to commend it to the panel and see if they could look into providing county council sponsorship for participants. I've certainly put both my kids through it and went with them, and it actually improves. I'm sure it improved my driving, let alone made them safer drivers in later years. So it's called the Under-17 Car Club. It was started by at least some people from Gloucestershire, and it's an amazing and really effective road safety initiative.
Okay, thank you.
I can respond, Chair. There are a number of initiatives that are used by fire and rescue services and local authorities nationwide. The one you refer to, I am aware of. They are very successful. Again, it's part of education. So it's about a process of us, when we move this forward, considering which is the most appropriate scheme for Gloucestershire. And if we can find the funding to do that, then obviously we will look at it. I can't make any commitments now. If you drop me a line, Councillor Horwood, reminding me of that, I will get it into the appropriate arena for discussion.
Thank you. I must apologise to Councillor Tipper. I have missed him out in the order, but it's your turn now, Councillor Tipper.
Thank you, Chair. A couple of issues I would like to raise while I got the opportunity is that just to introduce the subject, 8 years ago I had a hybrid vehicle and they're very quiet. And what I would like to raise is the aspect of when drivers drive them and when pedestrians are walking down a road and they don't look, because they've been robbed of the facility, or faculty I should say, of hearing. And basically they start to walk across the road without even looking. And what I'm trying to say is that both drivers and pedestrians should be educated in the fact that if electric vehicles are going to become more prominent, they should take that into account. So I think that should be introduced somewhere along the line. The other thing I would like to introduce or ask was that a few years ago, we were addressed by the Highways head planner about various aspects of how he did his job. And one of the things that we raised as councillors was the fact that near misses did not count in terms of when they gave no objection back to the district councils about a particular planning application. And all I'm trying to say is that near misses are near misses. It was almost an accident. So I'm just wondering whether a near miss can be recorded and shown as opposed to just being totally ignored. And what annoyed that meeting was almost all the councillors were up in arms about the fact that highway planner in particular did not raise this type of issue. And therefore the district council, because they could see no objection coming from the county, basically they gave the planning permission. And right now I'm dealing with, funny enough, with a planning application that is now demanding a TRO simply because this planning application was given, and frankly the problem that we warned about has happened, and now that we've got a real problem to deal with. Thank you very much for listening to me. Thank you, Chair.
Thank you. Denny, Councillor Neil, please.
Yes, just first of all, an observation. I think you always have to assume when you're driving that any pedestrian can't hear you, because so many of them, particularly the ones who are running, have got earphones plugged into their ears. So virtually everybody, Councillor Tipper was saying, seems to have lost the sense of hearing these days. That's just an observation. But my question is really this. I think there are a lot of groups around the county who are interested in road safety in their locality, and in particular in speeding. I'm a member of a local speed watch group. It would be really good if they knew who they could get in contact, so that they're not constantly trying to sort of reinvent the wheel, as you might say. You know, they looking at ways of controlling speeding, like ANPR cameras and vehicle activated signs and all that sort of stuff. I think they feel very much out on their own, because their feedback that they're giving is to the local constabulary who are generalists and don't have the expertise in road safety. Can you suggest how we can let my group and other groups, similar groups, know who they can contact to get some help and support in their road safety aspirations? Thank you.
I would suggest, Councillor Neil, currently that you need to make those representations through your local county councillor. Maybe your district authority can talk to your county councillor about raising that issue. As soon as we get this through Cabinet and hopefully we establish a forum and Senate approach, then clearly I would believe that what you've just raised would go through the forum, that would be backed up with the officer support for it then to be discussed in the forum, and then the outcomes of that discussion would go to the Senate. And I think the whole idea of joining a forum and Senate approach is to give, as you clearly said then, local people the opportunity to be heard, and those decisions then could be fed back to you after that has been fully debated and the Senate had reached a decision, to be sure that across the county, everybody that has a concern or has an interest gets that opportunity to feel part of the decision that's taken.
Thank you. Councillor Parsons.
Very much. It's very free, but I'm just going to touch on TROs. Sorry about that. I think what really looks very carefully is the consultation process. It starts a long way back, and I think takes a huge amount of time. I think it's important, but it's very, very time consuming. Basically, even to get things off the road, even to get things going, it's difficult to get any form of consensus sometimes to take forward a consultation, let alone the consultation itself. So I think that's an important issue. And I think obviously who pays for a TRO is another very important issue. But let us 2 comments on that. The one thing which I am concerned about at the moment is in fact speeding. I would like to see more progress on the ANPR, automatic number plate recognition cameras, which are coming in. And I know that that's being heavily promoted by the police. But overall, I think I very much welcome the report. I'd like to say not only, it just says to note, I think, is our recommendation. I'd like to say note and support at the conclusion of this meeting. Thank you.
Thank you, Councillor Parsons. Councillor Norman?
I completely agree with what Councillor Parsons has said, because yes, it is at the beginning part of the process of a TRO that takes the greatest amount of time. I am aware that 1 or 2 of them have taken 2 years to get through the outside of the consultation process, which must be a farce. I mean, that really has got to be looked at, has got to be addressed, but we don't hold the control of that. We will have to feed in, and talking to colleague councillors from other authorities around the country, they all share the same view. It is a common problem that has to be addressed. And thanking Councillor Parsons for the comment about where the road safety cabinet panel goes. Yes, the report was taken as read. It really would be helpful to me if this panel if this scrutiny committee endorsed the panel report and gives me far more armour when I go into cabinet.
Said one thing. You said 6 years. I'm dealing with one which I think is going live next week or thereabouts. It's been 20 years in the making, the TRO.
I can't comment on that, Councillor.
That's unbelievable. Unbelievable. Councillor Tracy.
Backwards here. Going back to what Martin said, going back about the cars and taking his children to be tested. We did that in Hempstead Meadow last year. And I think that was with the police. And they were like, people could take along also their cars to be checked over there. Unfortunately.
Sorry, Pat, that's quite different. These are under 17, so they're from 11 upwards.
Yeah,
and it's a 1 week course.
Oh, as the course, but
they don't have cars at that age.
Oh, sorry, I misunderstood you. Yeah, I got Dave not laughing, but anyway. So yeah, so we did that last year, and anyway, that's that. Jeremy, going back with the Santos Lane, I know that only goes up to Frogger Farm, and I know the stretch of road you're on about, and the only it's because it goes into the sign no speed limit, and it's only a stretch of road there. But then half of that belongs to the city, and half of that belongs to Tewkesbury Council. So when you're talking about like the money, would that would have to be shared with our? Would that have to be shared with our city and county money to do a 20 sign? But we have some people up there, it don't matter what you put up there, they will abuse that system, as you know. And it is, and when you pass Froggatt Farm, there's no way you can speed because it's all bends. So the question there is, how would one share the money if that had to be done? And then on these e-bikes, which Colette rightly so brought it up, yeah, going back, well, they seem to congregate in the cathedral grounds, going everywhere. So my question on this is, when we have anything in the city or on streets, there's supposed to be a license for it, like a street trading license. Now, these bikes pop up, and Jeremy can probably agree on this, where going into Seabourn Street, on the corner there's about half a dozen of those bikes there now. And they seem to be popping up everywhere on these streets now into residence areas. And so who controls where these bikes go? And they are dangerous. I totally agree. So my question is, when you go back, to discuss it, do they have to have a license to be on the street? and also who controls where they go, because they seem to be all around the city centre streets. Thank you. I'm going to leave the rest because that was answered. It's all right, Dave.
Thank you, Chair. Very simple answer to the first part, Pam. If it's a county maintained highway, the funding to do any work there with TROs or changes will come out of the county council's budget. That's quite clear. The issue in respect of the e-scooters and e-bikes, you're talking to the wrong cabinet member. You'll need to address your concerns in respect of the provision of those vehicles to cabinet member Nigel Moore. So I would suggest you drop a note to Nigel. The issues around the safety of those and the licensing of them, I don't believe they require a license. I'm not 100% sure. In fact, I probably am 100% sure, because if they required a license, that would have to been put in place before they were put on the streets, or each individual would have to be able to prove that they had a license to ride it. But we'll do a bit of investigation on that.
Thank you. And I think that draws an end to the discussion on the road safety report. Does someone wish to propose a course of action here? We've had a suggestion that we should endorse the whole report and send it on its way with our considerations.
Chair, if you could just check that everybody's in support of the report going forward with the comments that have been made at the meeting. I will record those and refer them to Councillor Norman. And if you just want to just basically a show of hands from everyone that they're in support, really it should be the adult social care members only who need to show their support.
Right. Can adult social care members please support by raising their thumb to endorse this report?
Noted. Thank you.
Thank you. And then that finishes the main body of the meeting. We just have the work plan recommendations to consider. Thank you, Martin. You're very kind.
Could I just add there that the work plan, we have a work plan for both committees, which we will share with the committees after the meeting. We've basically got the basic reports. We've got a final meeting of both committees in March. It's really, if anyone has anything to suggest prior to March of urgency, but basically at the March meeting, the committees will be asked to make recommendations going forward for the new committee to possibly consider going forward. So it's really just to consolidate, and if there's anything that anybody wishes to suggest going forward.
Joe, can I ask you a question quickly? I have got a question on pharmacy, but I see everybody's left the meeting, the hospitals and everyone else. So shall I put it on to the next meeting? It was I spoke to a resident yesterday over the pharmacy. So what do I do now?
I think if anybody wants to email me any suggestions, and then we'll take it forward for the March meetings that the committees can consider at that meeting. I think that's a good response, Pam. So if you want to email your concerns, I will share with everybody here at the meeting currently, but with everybody who has been present, and we'll put the proposals going forward.
Yes.
If everybody's in agreement.
Okay, I'll speak to you.
Okay, thank you.
Yeah. Thank you.
So that really draws our meeting to a close, I believe.
Okay.
I think that what we witnessed this morning is an fine example of cross-discipline working. Everyone's saying this is the first time this has happened, and this is the first time that we've all got together to sort out a major problem in the county. So there's lots of credits due to lots of people because of the COVID pandemic. And we have to thank those who have gone more over and beyond than would ever have thought necessary.
Yeah.
So thank you.
Thank you, Chair. But, oh God.
Thank you. I think the meeting is ended. Thank you, everybody. And I will be writing to the NHS professionals and to Sarah Scott, thanking them for today's meeting.